One, please start, sir. We are live.
Hello, good evening, everyone. It's a great pleasure that we welcome you all for the exciting webinar on the treatment and management of breast cancer 2022 and beyond. We have a pleasure to welcome and invite the program convener, Dr. Vivek Balatur, the consultant medical oncologist at Fortis Hospital, Bangalore, along with the scientific committee members, Dr. Rahul Sood and Dr. Vijay Agrawal. So good evening, everyone. We carry the greetings from the Garden City, Bangalore. Good evening, Dr. Vivek, sir. Over to you to start the proceedings, please.
Thank you, Tarun. Good evening, all of you. Greetings from Bangalore and Fortis Hospital, Bangalore. So, in association with Fortis Hospital and the Aegis of Cancer Research and Statistic Foundation, we are organizing this breast cancer webinar today. So, I welcome you all. It's my pleasure and privilege to have you all this evening on a weekend. So, I think we have been conducting a few of these webinars now in the absence of physical meetings and not being able to attend various conferences. I think this has become a way of, or a platform for us to discuss on many new things. And this on this occasion, I think we'll be concentrating more on the recent updates in San Antonio Breast Cancer Symposium, which has happened recently. So in the absence of those physical meetings, many of us wouldn't have been able to attend those meetings. And so when we are not trying to go there, we miss out on many of those updates. So I think we'll make use of this meeting for discussing many important abstracts and presentations of that particular meeting today. So without much time, I would like to request the first speaker of the program, Dr. Vijay Agrawal, to start his presentation on role of olaparib in the management of.
Sorry to bother you, sir. I think this is the old one. We will be starting with a panel discussion by Dr. B.K. Smriti, ma'am.
Oh, sorry. I think yeah. Thank you. Thank you for that information. So sure, we will do that small change. Yeah, absolutely, ma'am is here. Good evening, ma'am.
Good evening. Good evening.
I think we will start with the panel discussion.
Sure.
So I think in a way it is good because in the panel is about discussing some of the important aspects of newer diagnostic things in breast cancer. As we know, we have now seeing many more markers in breast cancer diagnosis. Like although the basic ERPR and HER2 remain very important markers for us in breast cancer, there are many more additional markers now have come in the way, like it can be predictive, prognostic, and some markers for resistance, like for example ESR1, PI3K, PDL1, AR, and now probably TROP2 also might come in the near future. So to discuss about all these things, I would like to welcome Dr. B.K. Smriti, who is a senior consultant medical oncologist at Lilavati and Bombay Hospital, Mumbai. Madam, I welcome to the session. It's over to take over and start the panel discussion, and I request you to introduce your panelists so that it will become easy for you.
Yeah, I'll just share my slides, please.
Yes, ma'am, all yours.
Are the slides visible and am I audible?
Not yet, ma'am. I mean, you are audible. We are very much audible.
Yeah. So I would like to thank the organizers for giving me this task of, discussing the diagnostics in breast cancer and where are we in 2022. It's a very vast topic and I've chosen certain subjects in this, and I would request all the panelists to be very brief and crisp in their replies. Let me call on the panelists. The first is Dr. Mona Mehta. She's the head of radiology and ultrasound at Lilavati Hospital. Then Dr. Gurudutt, who is the molecular pathologist. Dr. Megha Tandon, she's the surgical oncologist. Dr. Krupa Bajaj, who is the medical oncologist. Dr. Krupa Shankar, medical oncologist. And Dr. Biswajit, who is also the medical oncologist. And Dr. Kakoli, the medical oncologist. Are they all there?
Yes, ma'am.
Good evening.
Hello, ma'am.
Yeah.
Yes,
so
ma'am.
Let's get on with this. So, breast imaging has many modalities, and anything? Yeah, the breast imaging today has
Ma'am,
developed.
sorry to interrupt, but you need to share the slides first. You
I've
have not shared the
shared the
slides.
slides.
No, no.
I can. Now, are they visible?
No, ma'am, it's not visible on the screen. So can we share from our side?
Yeah, and give me the control.
Yeah, Tarun, you can share the, yeah.
Yeah, so come to the slide number 2.
Yeah.
Ma'am, this is slides in front of your screen. Now you can.
So, as I said, that breast imaging modalities are many, and we would like to, ask our Dr. Mona Mehta very quickly about what's new in the mammography field. Can you go to the next slide or give me the controls, please? Yeah. So what are the recent advances in mammography and evaluation of breast after neoadjuvant therapy and the role of MRIs? So could you briefly, educate us on this?
Yeah. Ma'am, can you hear me?
Yes.
Okay. So as far as recent advances in mammography it is the introduction of the full field digital mammography with 3D tomosynthesis. Now, this technique utilizes low dose X-rays and obtains images of the breast in thin slices from different angles. So what we get in the end is very high resolution images of the breast in a matter of seconds. And the advantage of a 3D tomosynthesis is that it delineates margins of the mass very well. Architectural distortion is beautifully seen. And it is especially useful in patients with type C and D breasts, which are heterogeneously dense and extremely dense, because there is a lot of overlap of the fibroglandular tissue. If we have an attachment like of a biopsy, then it is possible with the 3D tomosynthesis to even biopsy, say, microcalcifications which are not associated with the mass. And even clips can be placed under mammography guidance. And of course, one of the latest innovations is the introduction of contrast-enhanced digital mammography.
Yeah.
And, as far as the second question is evaluation of breast after neoadjuvant, the main aim of imaging would be to define or to delineate the exact extent of the disease before starting the neoadjuvant chemotherapy. And how is this done? This is done with the help of mammography, ultrasound, and dynamic contrast-enhanced MRI.
I think you could show the slides, please. Can you advance the slides?
Yeah, so this, can you see my pointer?
Yeah, you can just say next, because the control is not with me. Yeah.
Yeah. So if you can see, this is a conventional 2D mammogram, and I'm pointing out to this particular lesion. Now, the margins of this lesion are not well seen because of a lot of overlap of the tissue here. So now, in contrast, when we do the 3D digital mammography with tomosynthesis, you can see the speculations extremely well on this tomosynthesis image. You can go to the next slide. Yeah. So the same here, this is a 2D image and this is a 3D image, and where the microcalcifications and speculations are extremely well seen. Next, please. Yeah. So this is again a lesion which could have been easily missed. Even if this is a digital mammography, this is a conventional, this is the 2D mode of the mammography, and this is the 3D tomosynthesis. So if you just look at the mammogram, you may not be able to pick up this lesion. But the moment we run the tomo slices, you can see the margins of the lesion extremely well, and they just stare at us, so we can really pick up these lesions very well on the 3D tomosynthesis.
So I think now I would just ask Dr. Megha Tandon that when you get a patient with who has received neoadjuvant therapy, how would you like to image that patient before taking up for surgery? So Dr. Megha Tandon.
Right, ma'am. So as rightly said by Dr. Mona, that we need to have some assessment before surgery. If the patient is going for neoadjuvant chemotherapy, we need to mark and clip the area before putting the patient on neoadjuvant chemotherapy. And we usually do a MRI to see the response. So we use the RECIST MRI, RECIST criteria to see the response after neoadjuvant chemotherapy. And then, of course, before taking the patient to surgery, we'll have to repeat the MRI and find the exact size, the response, and the clipped, and only the clipped area with margin we would be able to remove, and we should be able to preserve the breast if that's the case, if that's what patient intended, and that's why the patient was put on neoadjuvant chemotherapy. So whatever imaging modality was done pre-neoadjuvant should be repeated before taking the patient to the surgery.
So Dr. Mona, can you quickly show the 3 slides you had to show the response? Next slide.
No, ma'am, this is the slide which is showing that we have clipped and we have done a hook wire. And this is the specimen mammogram, which shows the hook wire in place and the lesion which is out. So next slide, please. This is an image which is showing the contrast enhanced digital mammography. That is one of the latest innovations in mammography, where we take low energy, low kV and high kV images of the breast. And the image which is obtained is this, where you can see that this particular lesion, which is saying, is just showing a rim enhancement. This procedure is done with the help of, you inject iodinated contrast, just like a CT scan or an MRI. And in the end, what we get is an image which only picks up those areas which are abnormal and which enhance abnormal. Yeah. So this is the contrast enhanced dynamic digital mammography that I've shown in this image. Can we go to the next one, please?
Yeah.
Yeah, this is also another image where if you see that this is a 2D image, this is a 3D image. This 2D image shows this mass here in the outer quadrant of the breast. Here in the 3D tomosynthesis, you can see the spiculations well. And once we have injected the iodinated contrast and done a subtraction image following that, this is how the lesions appear. So there's not only one lesion, but now this lesion was not seen anywhere on these breasts. So the contrast enhanced digital mammography helps picking up additional images. It's like just like a dynamic contrast enhanced MRI. And it is particularly useful for patients who cannot afford an MRI, who cannot undergo an MRI. For example, those who have a pacemaker or those who are claustrophobic, then this is a very good alternative to a dynamic contrast enhanced MRI.
Yeah. So thank you, Dr. Mona Mehta. Now we move on to the other part of diagnostics. Next slide, please. No, let's go to the next slide, please. Next slide. Next slide. No, next slide. No, I think, no, these are, yeah. So what are the diagnostic tests in breast cancer? So coming to the histopathology, HER2 testing, ER/PR, PDL, and other biomarkers. Now, coming to Dr. Gurudutt, who is our pathologist on the panel, I would like to straight away come to the HER2 testing. Dr. Gurudutt, are you there?
Yes, ma'am.
So I just want to know from you, what is new in the HER2 testing according to the ASCO-CAP guidelines, which are published in 2018? And then, of course, this concept of HER2 low breast cancer.
Well, the new thing that happened was now it is advocated that first IC should be done, and they have divided it into 5 groups. So in first, if it is say HER2 3+ on IC, then there is no need for. You can
just move on to the next slide. I don't have the control. Yeah.
Yes.
Yeah.
And if it is group 5, that is negative, then you need not do it. So in between this 2, 3, and 4 groups, then you have to go for additional testing by FISH. So that is I think the change for the ASCO-CAP 2018 update. So it has put IC in the center, and whenever there is a say a problem with FISH, then you have to take a call by considering the IC. So that is the change.
Yeah. And now coming to our medical oncologist, Dr. Krupa Bajaj, can you tell me what is this concept of low HER2 breast cancer?
So low HER2 breast cancer, in the sense, FISH, you are talking about the ratio, ma'am, the 2+ you want to describe myself?
No, just move to the next slide, please. So this is what is HER2 low breast cancer.
Correct.
So could you expand on this, please?
Yes, ma'am. So it is usually called as 1+. Either usually 1+, incomplete membrane staining will be there. That's a barely perceptible staining will be there in more than 10% of the tumor cells. It is 1+. It is HER2 low. Usually we don't tend to push towards doing FISH in this kind of patients. Only when it's 2+, when there's dicey situation is there, when moderate staining at least is there in more than 10%, then we tend to do the FISH for this patients. But if it's an incomplete membrane staining, usually you don't get tempted to do the FISH in this patients. Those patients are called as HER2 low patients.
So it is 2+ as well as 1+. So 2+ FISH negative and 1+, of course, with more than 10% incomplete stain.
Correct.
That is taken as HER2 low, but the definitions are not universally accepted. That is the biggest problem with HER2 low.
Heterogeneity, yes, a lot of heterogeneity is there in this.
Yeah.
And in HER2 2+ also, the biopsy was proven as HER2 2+, which is negative. Usually most of the pathologists post-surgery, they do repeat it, whether it's 2+ or 1+
Yes.
Again. So
Yeah,
a lot of heterogeneity is there in 1+, 2+.
If it is on biopsy, then you should repeat on the resection specimen.
Correct, correct.
Swajit here, ma'am. Can I just put in a word? Because recently the Destiny 04 study got approval, and they published the results, not yet approved. So because of that, we are now looking at this particular subgroup called the HER2 low breast cancer as a separate group, which almost forms 50% of the patients.
Yes.
And they are classified as defined in this algorithm. And in these patients, if you use trastuzumab deruxtecan, there seems to be actually a survival benefit. And this is proven by the Destiny B04 results, which got published 2 weeks back.
Yeah. So
as rightly pointed by Dr. Biswajit Dubasi, even like 2+, 1+ also, they got a very good response. Even faint staining,
yes,
there's a great uptake is there. In TMH Destiny enrollment happened. I myself visualized 1+ patients also got a great response. Even the total shrinkage of tumor happened.
So the response rate was almost, in the initial thing was almost 37%. And the median PFS was almost 11 months. So that is what I was coming to. This entity has now become very prominent, and this is from a publication in 2020, where it shows that, what is meant by HER2 low. And as rightly pointed out by a medical oncologist, this has very good implications in the future for treatment of these patients. So we are expanding the armamentarium of patients who are, HER2 1+ and 2+, but FISH negative. And just go to the next slide, please. So you can see that these are all the potential therapeutic options. And as mentioned, that the antibody drug conjugates are the most promising therapies. And of course, you have some of the bispecific antibodies and vaccines also on the horizon. So I think we are looking at a very interesting aspect. Now, next slide, please. Next slide. Yeah. Now, coming to the next one is that the PD-L1 testing. So, Dr. Krupashankar Bajaj, Dr. Krupashankar, are you there?
Yeah.
Dr. Krupashankar? Okay, then Dr. Biswajit, are you there? Yeah.
Yeah. So for the PD-L1 testing, so the immunotherapy drug has got approval in early breast cancer with the Keynote study. But in the Keynote study, it is irrespective of the PD-L1 testing, and the approval is there. So I'm not sure whether for early breast cancer, I would still want to do a PD-L1 testing. You could do, because the responses will be much higher if your PD-L1 is high. But irrespective of the PD-L1, the approval is there. Whereas for metastatic breast cancer, in the first line, when you use the drug pembrolizumab, then you need to have a PD-L1 testing, because the score has to be more than 10, then the benefit is there. So probably in metastatic breast cancer, definitely you would do a PD-L1 testing. In early breast cancer, may or may not be required. And if you are doing the test, then it will be the companion diagnostics to the pembrolizumab, which is the 22C3 testing. And are the tests concordant? There is clear-cut evidence that there is no it is not concordance, you need to do the diagnostics depending on the drug which you are using. For example, atezolizumab has a different antibody, and you have a different antibody for the pembrolizumab.
Yeah,
I would like to add here, ma'am, one thing.
Yes.
So usually Ventana platform, DACO platform, for pembrolizumab, it is a IHC 22C3 we have to use. But the DACO is the standard one. Whereas for this SP142, Ventana is the standard machine. So if you
Yes.
see most across the world, like most of the people, even our own centers like TMH or Basatarka, we are having Ventana platform. So actually the paper is going to come, the standardization for SP142, yeah, IHC 22C3 on Ventana also, the paper will be coming soon next month. But most of the centers like tomorrow, even TMH, they used to use 22C3 on Ventana platform, but not DACO platform. There, its purchase is like much slower. Even in our center also, that's the same condition. And decent concordance is there. Even people who are not having IHC 22C3, they're doing with SP142 only, even for pembrolizumab. Even the early breast cancer, whatever you're saying, sir is saying.
Yes.
So other also.
So Dr. Gupta, what do you have to say on this?
Ma'am, I think for Pembro using SP142
Just go to the
is
next slide, please. Next
not a good
slide.
idea, because
Yeah.
what we have seen in our experience, SP142 is, I mean, like in our experience, we have done around 52 TNBCs on SP142 for Atizo, and the positivity is around 27% at 1% and above. So taking it for CPS is a bad idea. SP263 is better if you want to use it for CPS, though it will score it higher. But 22C3 or as a LDT done on Ventana Benchmark Ultra, it gives quite a good concordant results. That is our experience.
Yeah. So, sometimes it has been asked. Of course, now the question doesn't arise because in the metastatic setting, the atezolizumab study, they have, withdrawn it in the US
Yes.
markets. And of course, it's still existing here because of the discordant results of the two studies.
Yes.
So, some people have asked, have you ordered for both the tests if one is negative? But I think now that question is settled because I want to know from Dr. Dubashi that if you had both the options, which drug would you go for given the results?
In the metastatic setting, madam?
Yes.
Yeah, I mean, currently there is no doubt because of this confusion of two trials showing contradictory results, that they have withdrawn the label for the atezolizumab. So now the drug which is available is only pembrolizumab, and if you have a CPS score more than 10, then you could use the drug.
Yes,
So that is
right.
and this data is very clear that actually you cannot interuse the at least for the atezolizumab, the data was very clear because they did all the concordance this thing on test on the IHC by
Next
different
slide, please.
techniques.
Yeah.
And they have clearly shown that if you actually interchangeably use it, your outcomes are different. Actually, the SP142 will have a lesser positivity rate when compared to the others. But when you actually look at the response rates, they found that only with SP142, it actually correlated with the response. So you actually cannot interchange and use.
Yeah. Can you show the next slide, please? Next slide. Yeah, next slide. So this is, as you said, that, the overall percentage agreement is at subpar. So let's move on very quickly to the next question. Yeah, please go ahead with the next slide, please. Yeah, so now we have dealt with the IHC testing. We have dealt with, also the PDL1 testing. Now, Dr. Kakoli, is she there? Is she there, Dr. Kakoli?
Yes, ma'am, I am here.
Yeah.
I am here.
So what other testings do you do in, not in early breast cancer, but in metastatic setting, as far as the biomarkers are concerned?
Yes, ma'am. So we generally do, BRCA1 and 2 we do almost for all germline BRCA1 and 2, almost for all patients. And PIK3, generally I reserve it for second line most of the times. I generally don't do it upfront. And other than PDL1, that is. And MSI, well, it actually depends because I mean, it also gives an indication of a hereditary Lynch syndrome. So that is one aspect for which we are doing. Otherwise, therapeutically, I do not really use it. So these are mostly these are the tests, and Ki67 is because we have to keep that ABEMA data in mind. So Ki67 anyway is done on the biopsy. So that we keep that in mind. Ki67, PDL1, BRCA1 and 2. So mostly I'm in this, and of course, if the patient is affordable, then we in breast and lung we generally ask for NGS.
Yeah, so I'll come to that in the end about the controversy regarding NGS, but let's get on. Next slide, please. So this is just to do with the PIK3CA mutation. So when would you like to do it, Dr. Kripa Bajaj?
Yeah, ma'am. Usually, though the guidance suggests the first line is enough, like the PIK3CA is a standard mutation, it will not get mutated. It's once it is there, it is there. So usually post CDK4 inhibitor, 4/6 inhibitors, we tend to use it, not in the first line itself, because it's always better to use post CDK4/6 inhibitor. We are not going to do this in the first line, alpelisib, so we do use it later. If the tissue is available, then we'll do on tissue. If it is not there, then we'll go for ctDNA.
So Dr. Biswajit, would you do it on tissue or plasma, or how do you go about it?
Tissue is the gold standard, ma'am. We'll do it first on the tissue. With the plasma, the problem is if it is positive, it is okay. If it is negative, you cannot rule out mutation. So we have to do a biopsy after that.
Yeah, next slide, please. So this is about that 40% of hormone receptor positive and HER2 negative have PIK3CA mutations. And now I would like to come to Dr. Gupta. Which is the technique that you are using or the platform for doing this? You're muted. You're muted, Dr. Gupta. Yeah.
Ma'am, we use TheraScreen.
Yeah.
QIAGEN. That is used for FDA approved kit is used for reporting the PIK3CA.
Yeah. So just go to the next slide. There are some interesting data about. So this is what Dr. Biswajit has said. So I think we can just move on to the next slide. Now people are doing NGS, though, as was mentioned in the AB6 guidelines, of which I was a part, that NGS should not be routinely done in breast cancer. But this is a study which looked at PIK3CA mutations which are picked up by other techniques other than TheraScreen, which has only 11 hotspot mutations. Yes. And you can see that there are other mutations which are detected. Now, actually, PIK3CA studied in the 11 hotspot mutations seen in the TheraScreen study. So the question does arise that if you do an NGS and then you pick up another mutation not in the 11 hotspot, then what do you do? Well, I've spoken to the company also, and they said that at the moment it is approved for these 11 hotspot mutations, but they are not asking for which mutation the patient is having. So even if you have other mutations on the NGS, you could still use the drug, though you don't have the data on that. So this is what it is. Next slide, please.
Ma'am, sorry to interrupt. Last 5 minutes to sum up.
Yeah. This is now quickly coming to the genomic studies. So you have this situation of hormone receptor positive, HER2 negative breast cancer, and go to the next slide, please. So how do you take the treatment decisions? Do you use it with something online? Of course, you know that adjuvant online is no more online, so you can forget about that. But I would like to know from Dr. Kakoli, how do you solve this issue?
Generally, ma'am, Generally, we ask for, either the EndoPredict or the Oncotype DX, and for patients who are not affordable, we have one CanAssist in India. From a practical perspective. So that's the one we ask, and we generally base the decision on CanAssist. If for some reason the patient is not willing for the test, then we take the other factors into consideration, age and Ki67 and percentage of ER positivity and all that.
So when I said Predict, it is actually an online NHS tool. So Dr. Kripa Bajaj, could you expand on that? Because that's a very useful tool that since Adjuvant Online has gone offline. Yeah.
Yes, ma'am. It actually includes the age as well as tumor size and KC7 index and everything. So usually we used to a lot about it, but later we declined ourselves to the clinical factors. If patient is insisting, later to the can assist our Oncotype DX as my colleague Kakoli suggested.
Yeah, no, Dr. Dubashi could just say a few words and we quickly move on to the next part.
So I think what is approved are only two tests for predictive thing. One is only Oncotype DX is the only one which is approved as predictive for change of therapy. Whereas the rest of Mammoprint and all that is only for prognostic and it's not approved.
Yes.
And second thing is IHC4 again is not approved because it's not validated properly in the Indian setting. So only thing if you're using, we should use Oncotype DX. That's number one. Second thing is in what I do in practice is if I have a patient who is more than 70 years, then and is luminal A or luminal B, then I would straight away discuss with the patient, use the Predict Online and see the benefit of the therapy in that patient, and then straight away go for hormone therapy. If somebody who is less than 70 and is luminal A, which is Ki-67 less than 14 and cannot afford Oncotype DX, otherwise, if they can afford definitely Oncotype DX, they cannot afford Oncotype DX, then the patient can take a decision again whether will require chemotherapy or not. Otherwise, for all patients, based on just clinical factors, it's very difficult to decide which patients to avoid chemo and which patient to avoid hormone therapy.
Of course, this population is very small. It may be around 15% of our patient population who would require this decision making. Next slide. Next slide.
Most of our patients usually.
So this is what it is. The luminal 65%, but you can go by classical features as well and use genomic tests in only certain patients. Next slide. Yeah, next slide. Yeah, next. So this is what it is. Now coming to the, this is how you can use these genomic tests. Now quickly moving on to the last bit, and that is about hereditary cancer. Next slide. So who should be tested? So can Dr. Kakoli tell me? Very quickly.
We generally test all triple negative and hereditary means mostly I am assuming you're talking about BRCA member 1 and 2. Yes. So and hormone positive, whoever is eligible for olaparib. So we test in these patients.
So when do you test? Yeah.
Yes, we test it at diagnosis. We generally test it at diagnosis nowadays. And most of the times we are using targeted testing, not a multi-gene panel, and germline usually till now in breast cancer.
So Dr. Dubashi, what do you have to say? And Dr. Kripa Bajaj?
60 years for TNBC, less than 50 years for the hormone positive to get tested for the BRCA test. And if the strong family history is there for other thing, the other cancers like then.
Yeah. So next slide, please.
Always germ and the somatic.
Yeah. So if you look at the indications here in the GNA panel, as mentioned in the NCCN guidelines, it is almost encompassing all patients, and it's only about the age of 60 or likely to get, like in hormone receptor positive or the HER2 positive, you are less likely to get a positive test from this, but otherwise, it's expanding. And anybody using the multi-gene rather than targeted?
Ma'am, just for the testing, the only thing we should keep in mind that we could use NGS also for testing, but also we should remember that if anything comes negative, because some of those mutations are very large, they can be missed on doing targeted ones. So then we need to do an MLPA. So we should do an MLPA along with an NGS. That's a valid way of testing.
So that is very important that you can't happen to miss. So in that case, you would need to do an MLPA. Next slide, please. Next slide. Do you re-biopsy in metastatic setting? And how much is the discordance? So Dr. Kripa Bajaj?
Yes, ma'am. Whenever patient is on long-term hormone receptor for MBC, for first of all, patient is doing well for 3-4 years on hormone therapy, later started progressing. And then we try to tend to do whether there is any change in the receptor status or not. So you should.
Yeah.
Yes, ma'am.
So, it is seen in about 10 to 15% of the patients either losing the ER receptor or the HER2. Now, how do you deal with that situation, Dr. Dubhashi?
As rightly said by Dr. Kripa, that we do it for hormone positive mainly because positives become negative more commonly rather than negative becoming positive. And in that situation, then I would not consider putting them onto an hormone therapy and would give them chemotherapy probably and not put them onto hormone therapy. It has happened sometimes. We have had a strong positive hormone positive, but on relapse metastasis, they are negative and we put them onto chemotherapy.
So just look at the ABC6 guidelines. Next slide, please. Next slide. Please show the next slide. So if there is a difference, it is currently unknown which result should be used for treatment decision making. Since a clinical trial addressing this issue is difficult to undertake, we recommend considering use of endocrine therapy or anti-HER2 therapy respectively when ER or HER2 are positive in at least one biopsy, regardless of the timing. So I think as far as HER2 is concerned, even if there is a loss, and we know that if a patient has received neoadjuvant anti-HER2 therapy, if in the residual tissue, you may get HER2 negativity. So in those patients, you should use the anti-HER2 therapy. And as far as ER and PR is concerned, you could go for chemo first and then, but later on maintain with hormonal therapy. Next slide. Am I out of time or? Now this is about, the ER.
You need to conclude, please. We are running short of time, please.
Yes. So ER negative, PR positive, how do you treat those patients? Dr. Kripa Bajaj?
Yes, ma'am. We do actually ER negative, PR positive. It is strongly positive. Better to introduce CDK4/6 inhibitor in the beginning itself. And in this subset, abemaciclib has proven some benefit compared to other. It is not different in the maintenance or whatever it is, the visible crisis. It's not different from ER positive compared to PR positive. We do give the same maintenance for them also. But if you want to introduce hormone therapy, then better to add with the abemaciclib than other CDK4/6 inhibitors.
Yeah, but as mentioned, it should be actually treated. These are only 5% or less than that. And according to the guidelines, these patients should be treated as actually triple negative.
Negative though.
Yeah, I think this is the last slide. I just want to ask Dr. Gupta, is this really possible or it may be a lab error?
Ma'am, it happens sometimes. We get 2 to 3% such cases where PR is only positive. But usually PR, very few cases we have seen, I mean 2 or 3 where PR was more than 20%. Otherwise, it is 5%, 10%. I think that those cases should be taken as negative only.
Yeah, actually the last 2 things I had to discuss was, the use of liquid biopsy and NGS. But since both of them are not established and, they are only on the horizon, especially the only approved is the PIK3CA mutation, but we do not use. Are you using ESR1 mutation analysis anytime, Dr. Dubhashi?
Currently, no, ma'am. Except that interesting study of that PADA study which came up.
Correct.
Interesting. So otherwise,
yeah,
no.
That they're randomizing those who are on the aromatase inhibitors with the CDK4/6. If they have an ESR1 rising, then they would change the aromatase inhibitor to fulvestrant. So that is an interesting study that we have to look forward to. So I think with this and NGS, as I mentioned, and it was mentioned in the ABC6 guidelines as well, should not be done routinely. And, it is only in certain circumstances. And there was this study presented by Andrew Fabrici in the SABCS just concluded, where he showed that only if the SCAT1 and 2 actionable mutations are found, that it has any benefit to the patient, and that too if you have the actionable drug. But otherwise, it is of no benefit. Do you agree, Dr. Kripa Bajaj?
Sorry, ma'am. I just lost your voice. Actually.
NGS.
Yes, ma'am. Yes, ma'am.
Yeah. Do you do NGS?
No, I never suggest NGS, ma'am. Only
Yeah.
in TNBC patients, when patients are very enthusiastic, foundation tests, they do opt, but we never suggest to do NGS.
So I think with that, I would like to thank all the panelists and also the organizers for giving me this opportunity. Thank you.
Thank you, ma'am. Thank you so much for your very informative, detailed discussion on the diagnostic aspects of breast cancer. So I thank all the panelists, Dr. Kakoli, Dr. Biswajit, Dr. Kripa, Dr. Megha, and Dr. Gurudat. Thank you all once again. So with that, I think we'll move to the next session. So we'll go back to the first topic discussion of the evening, that is presentation by Dr. Vijay Agarwal, with a consultant medical oncologist at Bangalore. So he'll be talking on role of olaparib in the management of germline BRCA mutated metastatic breast cancer. So particularly alluding on Olympiad trial on testing and treatment management of this subset of patients. To Dr. Vijay Agarwal. Dr. Vijay, who is a senior consultant medical oncologist at Aster CMI Bangalore.
Hello. So the next session will be of Novartis only and will be moderated by Dr. Krishna Prasad, sir.
Vivek, I think there's a panel discussion by Dr. Krishna Prasad. The talk by Dr. Vijay Agarwal is not there today. If the organizers can correct me or Dr. Vivek, I don't know.
Yes, you're right, sir. You're right. So Dr. Vivek will have a panel discussion.
Okay. So we'll move on to the next session, which is again one more panel discussion. So the topic is living longer and living well. Now a reality in patients with hormone positive, HER2 negative, advanced breast cancer. So to discuss more on this topic, I would like to request Dr. Krishna Prasad, who is a consultant medical oncologist at Mangalore Oncology Center. He is the senior there. So over to Dr. Krishna Prasad, sir. Sir, are you there?
Thanks, Vivek. Yeah, I am there. Am I audible? Am I visible?
Please,
slides are visible?
Yeah, we can see the slides, sir.
Yeah, I think all my 5 panelists are there. Dr. Shrilesh from Calicut, Santosh and Aditya from Bangalore, Karthik from Manipal, and Suman from Chennai. So, so today's basic discussion would be on hormone receptor positive metastatic breast cancer. So if you look at it, I'd just like to know, Shrilesh, what is the percentage of hormone responsive positive breast cancer you see in your practice?
Good evening, sir. So basically it is around, yeah, it is around 50 to 60% the metastatic setting.
Okay. Santosh, is that the same with you?
Yes, sir. I think I would agree with Dr. Shrilesh.
Yeah, I think one of the papers published from Bangalore, Kidwai Center, shows that the overall hormone response positivity in Indian population is around 40 to 50%. So just coming to a case, a young lady, mother of 2 with back pain since 2 months, comes and wheeled in a wheelchair, and bone scan shows extensive metastasis. PET CT shows a right breast lesion, multiple bone mets, and 5 liver lesions. Liver functions are normal. Biopsy is IDC grade 3, ER positive, PR positive, HER2 negative, and Ki67 40%. Aditya, your thoughts on such a patient?
So young premenopausal lady with disease bulk, but not in the actual definition of a visceral crisis. So in a way, maybe chemotherapy could be discussed, but also given the recent data that we have with CDK4s, combination of hormone with ovarian suppression and CDK4. So both of them are valid options. Maybe a few years back, 4 or 5 years back, I would have said definitely chemo. But given the fact that she is young and we may want to save some lines for later, I would want to probably start with hormone, ovarian suppression, and CDK4.
Fair enough. Karthik, in Manipal, what do you do with such a patient?
think this is an ulcerated breast lesion who has come on a wheelchair. I don't know, maybe I am little old fashioned, but I would like to go with chemotherapy. Yes.
You
I'm
are
more
old
comfortable
fashioned,
that
but
way.
not old. Yeah. Suman, a young person from Chennai, what is your thoughts? Suman, are you there?
Hello.
Yes, Suman. I think we'll get back to Suman later on. So like how there is a thought process of using chemotherapy in such young patients with such a bad disease. But I think this was the same thought process. If you look at this consensus recommendations, just I think 3-4 years back in 2018, you can see that most of the medical oncologists in India would have used chemotherapy upfront. I think Karthik was definitely part of this. So however, the things are changing, and we know now that endocrine therapy versus chemotherapy, there are multiple studies, there are multiple publications, and it is now pretty clear that there is no chemotherapy regimen with or without targeted therapy, which is better than CDK4/6 inhibitor plus hormonal therapy in terms of response rate as well as in terms of progression-free survival. Shrilesh, is this your thought process, or would you think that chemo would be the first thing?
No, sir. My choice would be hormonal manipulation only, sir. Chemo, I will, for a frail lady coming in wheelchair, I think I would prefer hormonal manipulation rather than chemotherapy.
Okay. Suman, I think I can see you there. So you are the youngest one among us. What would you think?
So yeah, the same. I think I'll go with CDK4 inhibitors with ovarian suppression and reserve chemotherapy. Though the knee-jerk reaction will be to start with chemo, I would resist that given the new data. So I'll start with CDK4 and ovarian suppression, and then keep chemotherapy maybe for later line.
Yeah. So I think in general, I think 4 out of the 5 panelists would go with a combination of CDK4 inhibitor plus AI. Dr. Karthik would go with chemotherapy upfront. Having said this, it is pretty clear in the same meta-analysis which I've showed you now. It was very clear that if you're not able to afford a CDK4 inhibitor, or for some reason CDK4 inhibitor is not given, then probably it is better off that you start with chemotherapy and then take up the patient for hormonal therapy in such patients. So even if this patient is in visceral crisis, Santosh, even if you have a patient with visceral crisis, imagine this patient's bilirubin is 1.8, bordering now. What would your thought process be? Now there are papers like this one from Shaina saying that some experience with using this combination even in patients with visceral crisis.
Sir, the degree of visceral crisis varies from patient to patient. If it is like a really desperate situation, maybe I would try to tilt towards chemo, but as much as possible, I use the combination of AI or fulvestrant with CDK4/6 inhibitors.
Aditya, what is your thought process? The same lady now has bilirubin of 2.
No, but in this, I think I would like to agree with Karthik sir a little bit, because young lady, we don't know how much time we have to try and salvage her. The thought process of saving chemo for later lines may not be in question here. There is data, even new data suggests that in visceral crisis you would want to use, but 29-year-old lady, I would take chance and give some chemo. Here, though, it is very hard to refuse chemo here.
Fair enough. Fair enough. So, Suman, you have chosen, hormonal therapy with AI, and we now know that among hormonal therapy, probably fulvestrant has got some benefit, especially in patients without visceral disease, according to this Falcon. Now, based on this Falcon trial, which hormonal partner would you combine with CDK4 inhibitor?
Ideally, since she's premenopausal, I will not risk using letrozole. I just go with fulvestrant along with CDK.
Fair enough. Karthik, imagine your option of chemotherapy was not allowed and you're going to start CDK4 inhibitor with hormonal therapy. What would you do?
Yeah, I think letrozole with CDK is a good option here.
Okay, and of course you would add OFS.
Yeah, along with
isn't it?
ovarian suppression, yes.
Fair enough. Shrilesh, what about you? Are you concerned that fulvestrant is a better drug?
No, sir, I will reserve fulvestrant for second line only. I will usually, my personal preference is always letrozole with ovarian function suppression along with CDK4/6 inhibitors.
Okay. Santosh, regarding the Parsifal trial, which actually showed that whether you give fulvestrant or letrozole with palbociclib, there is hardly any difference. In fact, in a patient like this who has got some lesions in the liver, probably it would be better off with using AI. What is your thought process on this Parsifal trial?
Yeah, I mean, there's a good trial to look at when deciding between fulvestrant and AI. However, there is additional data that patients who get fulvestrant do probably better if they had bone only metastasis, and somebody who is like a typical metastatic hormone receptor positive breast cancer who has bone only metastasis, I tend to use a combination of fulvestrant upfront. Otherwise, would tend to go with the anastrozole, letrozole combination with CDK4/6 inhibitor, just mainly because of convenience sake.
Fair enough. Aditya, imagine this patient has come to you. You have given her 6 cycles of taxane. Now, what plan is yours? Would you give her CDK4 inhibitor with AI, or what would you do?
Ovarian suppression, AI, and CDK4. I do agree with all my other panelists because it is convenient to use oral letrozole. I've already called her back to the hospital 6 times to give chemo. Don't want to call her back again monthly to give fulvestrant. So maybe reserve fulvestrant for a little later and give letros ovarian suppression with CDK.
Fair enough, yeah. So, Suman, your thoughts on treating such a young lady? What are the challenges you think?
Challenges, of course, is resistance itself. So ERSN generally it happens within 6 months, 8 months, so just months time until we had these CDK4 inhibitors. Now we talk about years, at least a year before she comes back with some progression somewhere. So that's the first problem. Other than that, most of the premenopausal patients are quite compliant with therapy, so they do come. So once you offer, that's why I go with fulvestrant. Well, compliance is good actually with fulvestrant. If you give one injection, you do surgery, you give an injection, and then you give tablets. I think the compliance is more. That's just my point.
Fair enough, Suman. And I'm sure I worked in Tamil Nadu. People love UCs there. So they love injections. So Shrilesh, your thoughts on this young age at diagnosis? What is your thoughts on such patients?
So young breast cancer is considered as a very aggressive, sir. So when I passed my DM, so we tend to use chemotherapy for young patients that are hormone receptor positive. But nowadays, because of this, we have this Monalisa 7 and all these trials. We are very confident that hormonal will do as good as, even more good than chemotherapy. So I think even if they are aggressive, but just by menopausal status and that aggressiveness has gone now. So
fair enough. But we generally know that such young patients have got a very high risk of relapse and death. They are pretty symptomatic, and the quality of life is very low compared to older patients because they are inherently much more active people and a lot more responsibilities too. So do you think overall survival is extremely important, Karthik, in your patient with advanced breast cancer?
Yeah, I mean, because definitely it is very important because here we are not talking about PFS. This is a young patient, so we have to tell about how long the patient lives. So definitely overall survival is a very important landmark here.
Okay. So Santosh, this Monalisa 7 trial, just the updated results which are published. Can you just throw some light on this, regarding the overall survival?
Yeah, it was done in the premenopausal age group or the perimenopausal age group, where a combination of ovarian suppression and the ribociclib and aromatase inhibitor or tamoxifen was used, and they found improvement in PFS and OS that was significantly better than the placebo-controlled arm, and is one of the few studies which has shown OS benefit compared to the other competitors that these molecules have.
Aditya, your thoughts on this? I think even 48 months with the AI and placebo is excellent. 4 years for a young lady like this.
Correct. So essentially, when we were training, we used to look at PFS as the endpoint for metastatic chemotherapy trials. It is quite refreshing that we have OS as an endpoint for any metastatic cancer trial. And as Karthik sir said, OS is the reason why we all have our job. So the actual OS data does sort of reaffirm our choice in using a particular CDK. So having an OS data definitely does make me that much more confident in picking a CDK4 over B CDK4.
So I think in other words, apart from the overall survival, we see quite a good quality of life with these younger patients. And whether it is in such young patients in the MONALEESA 7 trial or the MONALEESA 2 and 3, mainly the postmenopausal women, we see overall survival benefit. In fact, the time to chemotherapy is also significantly prolonged with the ribociclib, and the overall health status is also excellent. So there are 2 updates which we have seen. We have seen the MONALEESA 7 update. The MONALEESA 3 update, which was published last year, showed an excellent benefit, 31.1% versus 46% at 5 years. And Suman, your thoughts on this MONALEESA 3, wherein also they said that even patients with more than 3 metastatic sites, liver, lung, those bad diseases also significantly benefited with ribo.
Yeah, I do go with them because in the trial, if you see the response to treatment is as early as 6 weeks. So given that the term of visceral crisis is going away day by day, so now we have visceral disease and visceral crisis. So slowly we'll pass on the benefit to CDK4 inhibitor itself. So we are coming to those times. So now even if we have liver lesions, we can start CDK4 inhibitors unless we have a liver function decay. So that's where we are heading.
Fair enough. So Karthik, your thoughts on this updated overall survival published 2 days back in NEJM, MONALEESA 2?
Yeah, I mean, pretty interesting. MONALEESA now everywhere, MONALEESA 2, 3, and 7 all has a OS benefit. So big boost for ribociclib, I guess.
Yeah, yeah, I know that MONALEESA is really, both 2, 3, 7, all the 3 have shown excellent overall survival benefit. So lengthy paper in NEJM, but definitely showing that significant overall survival benefit. Now considering that we have 3 CDK4 inhibitors, Shrilesh, how do you choose your CDK4 inhibitor?
Basically, sir, I don't think that there is any difference between these 3 drugs. But my personal preference is ribociclib because the initial cost is less. So that's why. Then also I have so many patients, but they are all doing good. Abemaciclib, I had one patient who had severe diarrhea, so I am scared to use abemaciclib. So palbociclib and ribociclib, it is almost equal in terms of efficacy, I feel.
Santosh, your thoughts, which is your go-to drug and why do you use that?
I have used both palbociclib and ribociclib extensively, and we also had a clinical trial with abemaciclib. So I kind of have a take on all of them. Palbociclib, yeah, the only main, obviously, the trials have not shown OS benefit. Other problem with palbociclib is there is significant neutropenia that we face, and many times I had to go down to 75 milligram of dose for many patients because they have grade 3 neutropenia, which is not the case with ribociclib. The side effect profile is much better tolerated compared to the palbociclib. I mean, with respect to ribociclib. Hence, I switched to completely recently to ribociclib, and we all in addition to that, we have the OS data to support us.
Fair enough. Aditya, do you think that the preferential inhibition of CDK4 as well as the high amount of free drug concentration makes a difference?
Not in every setting. Maybe if somebody has CNS disease or spinal disease. So I had a patient with intramedullary Mets, hormone positive. In such a scenario, maybe I might have picked abemaciclib, but otherwise it doesn't make too much of a difference whether it is just a CDK4 selective or a CDK4 and a CDK6. So all of it, ultimately boils down to whether it's premenopausal, then yes, then clear cut ribo. If there is some CNS disease, then maybe clear cut abema. But otherwise, all of them are almost the same. There is no choice. I think in terms, if we talk purely in terms of cost, I know academic discussion we shouldn't be, but palbociclib is slightly more economical because Pfizer has a separate patient assistance program depending upon the income, but I don't think that should make too much of a difference in the overall picture.
Suman, your thoughts on your drug choice?
Drug choice for premenopausal, there is no question. I still go with ribociclib. Though there are new data that abema is also effective. There is the palbociclib I very seldomly use. I have burned my hands before I lost a patient neutropenia. And then regarding abemaciclib, there are very specific indications. Recently, I started a patient who had very severe osteoporosis, but still patient wanted CDK4. So abema is the only drug which can be given alone. So that patient I started abemaciclib. Other than that, most of the patients, even cost effective, I think ribociclib is the most cost effective among the three. So most of the time it ends with ribociclib. There are very few indications which I use abemaciclib.
That's an interesting indication for abemaciclib. Karthik, your choice and why?
I think Aditya has rightly spoken. I think we should use what we are comfortable with. There is no head-to-head. There is nothing which is superior to others. And as everybody has correctly pointed, if in case there is a brain mets, maybe abema will score over others. But I think we are very comfortable using palbociclib and ribociclib because it has been there in the market since quite some time. And palbociclib, of course, because of the patient assistance program, we have given n number of palbociclips, and even though there are neutropenias, febrile neutropenia episodes are very less. I have not lost even a single patient due to palbociclib as such. So according to me, palbo and ribo both are okay with me because I've been using it since quite some time.
Yeah, my issues are with palbociclib. When we order the next lot of drugs and then we have to reduce the dosage, by the time already 125 mg has come, sometimes I get caught what to do with that. Problem with the ribociclib is I have no idea how to do this QTC reading. And problem with abema is sometimes we end up with quite significant diarrhea, but not at all common. So do you monitor all your patients like this? What is your usual monitoring process, Shrilesh?
So for ribociclib, I personally probably use ribociclib. We do an ECG at first, then after 15 days, we do ECG, CBC, LFT. Then again, after 28 days, we do the same. Then after that, just we do CBC and LFT. We don't usually repeat ECGs. Only 3 ECGs in the first month.
Okay, fine, fair enough. Santosh, you also do the same, or is there any change?
Yeah, I agree with Dr. Shrilesh. ECG is an additional monitoring that is required for ribociclib, and to some extent electrolytes, magnesium, these things we need to, and LFT, that is an additional requirement. We can get away by just doing CBCs for a long period of time with palbociclib.
Okay. Aditya, do you do the day 14 CBC, ECG and LFT, and have you changed anything till now doing that?
So I do it on day 14. We don't have such a busy practice, so I do it on day 14, but till date I have not changed in anybody.
Okay, fine. So I just reiterate that in Mona Lisa trials, what they've shown is, yes, there are some side effects, but the discontinuation rate is very low. And interestingly, reduction of the dose does not compromise the overall survival benefit. Suman, how liberal are you in reducing the dosage? In other words, what percentage of your patients actually you do your dose reduce?
No, for ribociclib, I seldom reduce dose. For palbociclib, it's inevitable. Mostly I reduce dose for all the patients. Ribociclib, it happens only after 5-6 months. I have reduced dose by one step for 2 patients. Otherwise, they go well with 1 week gap. 1 extra week gap will correct the neutropenia, so they go on.
Yeah, fair enough. Karthik, have you dose reduced ribociclib? If so, are you now comfortable with this study saying that it doesn't matter much?
Yeah, I have started reducing the dose much before this study, so I'm right now comfortable. So 600 mg, I feel that I mean there are subsequent, I mean substantial number of patients. I can tell maybe around 15% of the patients, 20% of the patients who will not tolerate this dose. I need to come down to 400. There may be LFT impairment, there may be neutropenia, but definitely yes. Palbociclib, I can tell 30 to 35% of the patients I do reduce the dose to 100 mg.
Yeah. So Santosh, your final thoughts on these Mona Lisa? Has these Mona Lisa made a different drastic change in the or a paradigm shift in the way you are treating your patients?
The presence of the OS benefit, when all the other studies have also done a placebo-controlled study, does help the cause. However, there are differences in the way the studies have been conducted, whether they've taken first line, second line, versus they've allowed chemotherapy prior to using the CDK4/6 inhibitors, etc. Just because of the tolerability, improvement in quality of life, and an effective PAP, that also helps to make a decision in favor of ribociclib when we are choosing between the CDK4/6 inhibitors.
Excellent. So if the organizers give us time, we'll just spend 5 minutes on the next slides. Is it okay?
Yeah, so 5 minutes left for the session to.
So what after CDK4 inhibitor? Suman, what do you do? Patient has progressed now 1.5 years. You've given her a good quality of life. Now patient has progressive disease. What do you do?
PIK3 testing I do.
Okay. Have you continued CDK4 inhibitors and changed the hormonal therapy ever?
So yeah, PIK3 testing. So if it's positive, I go with PIK3 inhibitor. And if negative and still patient is not fit for chemotherapy or not willing for chemotherapy, there are some trials which give abemaciclib as second line even after other CDK4 inhibitor progression. So other than that, it will be mostly end with chemotherapy.
So in the trials also you can see that patients who what is the percentage of people who receive subsequent CDK4 inhibitor? It's roughly around 20% of them. Karthik, would you use CDK4 inhibitor in second line, somebody who's progressing on one CDK4 inhibitor? If so, would you change it or would you just continue the same, because that is also an option?
I've done everything, sir. I've continued the same, changed the hormones. I've basically changed the, CDK inhibitor. But mostly what happens is it depends on how much it has progressed. If there's a gross progression, there is only 1 or 2 bone metastasis, maybe I'll retain the CDK inhibitor and change the hormone partner, because a patient would have paid from his pocket for 10 months ribociclib and I tell that, okay, stop it. Then they may be angry on me. Definitely, yes, we discuss scientifically, but I feel that I'm comfortable basically changing the hormone partner here. But if there is a gross progression, maybe everything, PIK3 is a good, if it's mutated PIK3 inhibitor and fulvestrant is a good option here.
Fair enough. Santosh, what would you do? Would you change, and what partner would you change? Would you change the CDK4 or would you change the hormonal?
I agree with Dr. Karthik to some extent, but my second choice of agent is based on the PA3CK mutation. And if it is a mutated patient, would try to convince the patient to take on alpelisib. However, otherwise would change to fulvestrant plus or minus the ribociclib, palbociclib based on the degree of progression. Though there is no hard data for this.
Yeah, there's a trial Trinity where they're trying to see whether continuation of ribo is going to help. And like how all of you have said, if you do a PIK3 testing and if it's positive, better to go with the alpelisib rather than continue the same. So Aditya, I think this has already been discussed. Ideally, we should do a testing on the biopsy specimen. If it's not available, you can do it on the blood. If blood is negative, then you need to definitely repeat it on the tumor. Is it a fair summary, Aditya, or would you change anything?
No, I agree. But at least the practical considerations would make us do the same thing.
Fair enough. Fair enough. So it is also clear that if it is positive in the blood, the response is as good as if it is positive in the tissue. So the final slide, Karthik, what is your consideration before starting this alpelisib? What are the things you look for and what are the problems you have faced?
Sir, frankly speaking, I have not given alpelisib to any of the patients. No problems at all. So yeah, but I think I'm aware that if at all I'm going to give alpelisib any of the patients, maybe diarrhea, rashes, and I mean, these are the main neutropenia. So these are the things which probably I need to be aware of.
Suman, your thoughts on when you use alpelisib, what do you look for and what are the problems you have faced?
Yeah, for alpelisib, elephant in the room is glycemic control. So it's very, very high. Almost all 100% of patients will have a glycemic problem. So we start with doing HbA1c, fasting blood sugar, and see the glycemic control. And apart from the sugar control part of it, the other side effect profile is as good as any TKIs. So it's the same. So one thing to remember is the blood glucose levels.
Fair enough. Shrilesh, is it the same and how comfortable are you looking after the diabetic level?
Sir, I have used only in one patient. Actually, patient progressed after letrozole plus palbociclib for more than 3 years. Then we did the PIK3CA testing in the blood. It was positive. We started on alpelisib plus fulvestrant. But the glycemic control was very horrible. It was 500, 550, and patient was very irritated because 3 years she was doing fine. Then after that, so I had to stop in between. So it is. I don't think that it's a very comfortable. Maybe because of our experience, maybe the problem.
I feel experience with this drug and also experience with managing diabetes is a big problem. I think we need to get the endocrinologist into the picture immediately or as soon as possible. So I think I would end here by saying two things: that results of Mona Lisa trial clearly show significant overall and progression-free survival benefit of adding ribociclib to endocrine therapy. And it has been a paradigm shift in the way we manage metastatic breast cancer who are hormone positive. And when they progress, if patients are PIK3 positive, which is around 40% of the time, alpelisib with fulvestrant really is useful. But we have to be very careful with two things, with rashes and more importantly with the glycemic control. I think with that I will end. I thank all my 5 panelists for this excellent discussion. Thank the organizers for giving me this opportunity. Thanks a lot, dear.
Thank you, sir.
Thank you, sir, for that detailed discussion on CDK4/6 inhibitors in advanced breast cancer. So it was a wonderful discussion, I think, about these 3 drugs. So we are spoiled for choices, I think, with these drugs and all of the novel situation. So I actually concluded I had a question. I think I would be asking that question to Dr. Amit when he presents his presentation. So thank you very much once again. So we'll move on to the next topic. So after having discussed about the CDK4/6 inhibitors, now we'll move to the next section where we will hear the evidence for that. So to talk on from clinical trials to clinical practice, navigating management with CDK4/6 inhibitors. So I would like to request Dr. Amit Rotan, who is the HOD and Senior Consultant Medical Oncologist at Manipal, Bangalore, to present his evidence for this.
Thank you, Dr. Vivek. Thank you, Dr. Vivek, Dr. Sood, for inviting me. So I'll start with sharing my slides. So I heard that excellent discussion. And what happens is the discussion happened before the talk. So I got everyone's views. Now you will end up hearing my views. So eventually it's almost the same as what it was discussed. So but we'll quickly run through it, and my topic will be from clinical trials to clinical practice, navigating management with CDK4/6 inhibitors. So we've seen how the first line space has changed with the hormone positive metastatic breast cancer. We started off with just tamoxifen, and we went on. We used to talk a PFS of 6 months. Then the AIs came in. We said 10 to 12 months. SERDs came in. We said a little better than that, but not too great. And then with CDK4/6 AIs first line setting, nowadays we talk of a PFS of 24 to 28 months. And this is very consistent. We have seen how CDK4/6 came into play, understanding how the CDK4/6 with cyclin D1 is overexpressed in breast cancer, how the cyclin D1 is overexpressed in breast cancer, how the inhibition affects the G1S checkpoint, and how blocking this becomes very important. We're using this information for breast cancer for treatment, but I think if all of you have seen the recent new CDK4/6 inhibitor data, the data of trilaciclib, if you've seen this new IV CDK4/6 inhibitor, which we are using this information, the side effect information, for clinical practice. So just to talk about it, if you're using the drug called trilaciclib, which is approved by FDA, it is suppressing your blood counts during treatment. It's an IV CDK4/6. It suppresses your blood count. You give the chemo, and then the blood counts will recover after that. So you don't have neutropenia. So FDA approved it for preventing neutropenia. So we have a CDK4/6 now, IV, approved for preventing neutropenia. It is approved in small cell lung cancer with carboplatin etoposide in the first line setting. So see, this is how the science changes. You learned about CDK4/6, you learned cyclin D1, you used it in practice for your breast cancer cells, and now you're using that information of CD6 inhibition and using it to prevent neutropenia in cancers. So amazing way the science is changing, and this is how we keep learning new things, and that's the way we move forward. So first line therapy, I think we've heard that excellent panel discussion. Let me just run through data sets just quickly, and then we'll just, I'll probably just conclude it putting it all into a summary. We saw the first data, palbociclib letrozole. Palbociclib was the first CDK4/6 inhibitor which came into the market. The data sets of PALOMA-2 was using as first line data, and we saw how there was almost doubling of progression-free survival, 14.5 months going to 27.6 months, hazard of 0.56. And with this, the approval came in. I think 2016 October was when the drug got approved in India, and I think since then we have used this drug extensively. There's really no doubt about it. I recently, just last month, saw one of my second patients started on palbociclib letrozole. So she's 5.5 years down the line with metastatic setting. She's still containing palbociclib letrozole. So this is how you get so excited about. You start seeing this group of patients after years and years and years, and they do well on one line of therapy. So that's the way the data goes. We saw that every subgroup benefits, be it visceral disease or non-visceral disease, bone-only metastasis, treatment-free interval, anything you talk about, these patients benefit. And then the data came for MONALEESA-2. That was using ribociclib letrozole in the first line setting. And again, it's very similar curves, 16 months going to 25 months, hazards of 0.56, bang on, exactly the same, similar curves. And then you saw the MONALEESA-2. This year, we saw the overall survival. So this time, this was very impressive. This is the first time we saw overall survival in the first line setting. 51.4 months with ribociclib in the first line setting, going to 63.9 months. So more than 1 year survival advantage in the overall survival. Now one can look at this in different ways, trying to understand what was. So whenever you see OS data sets, always please look at what were next line of therapies used. And that's very important to understand the overall survival. But it's so difficult to get overall survival in first line setting. And this is the first trial to get it. So no doubt about it, MONALEESA-2, very impressive data sets, 1 year survival advantage. Again, if you see, all the subgroups benefited with overall survival. So really there's no one where you'd say you'd prefer to use it. Everyone benefited when you added ribociclib with letrozole. The third drug, MONARCH 3 study using abemaciclib. And then again, here you see almost the same thing. You see the hazards, 0.54, 14.7 months going to 28.8 months with abemaciclib. And again, the benefit is exactly the same. All the subgroups have been seen, and especially in abemaciclib, you keep talking of high-risk disease, you keep saying visceral metastasis, liver metastasis, and again, you see the benefit is there and exactly the same. So we have these, of course, we cannot disregard MONALEESA 7 because this is a very different trial done for the pre-menopausal population. And I think this takes a sort of an initiative to really take up a whole group of premenopausal women and treat them with ribociclib, with hormonal therapy, of course, using LHRH also in comparison. And again, we see the same kind of a progression-free survival, 13 months going to 23 months. Hazards are again 0.55. And we also saw the overall survival data, 48 months going to 58 months, which is statistically significant. And we heard this, MONALEESA has all the overall survival data sets already. So if you put them all in perspective, I think the bang there is the PFS, and that's exactly 0.54, 0.55, 0.56. It's exactly the same in all the trials. But you have OS data of MONALEESA 2 and MONALEESA 7 in this setting. Does that mean this drug is very superior to the others, or the others are inferior to this? Absolutely no. I think with this kind of PFS, which you're seeing everywhere, you kind of think they're almost the same. I think the first-line trials, that's what they teach us, because these are very uniform population of patients. They're not like the second-line trials where you have different populations. Here, the population was very uniform. So all of them showing the same PFS, showing the same kind of a benefit. But yes, the OS data of PALOMA 2 and MONARCH 3 has still to mature. And I think with time, we will see as it matures what the data sets come out. So then the difficulty comes, how are we going to choose? And what are we going to do in choices? And that's difficult in every clinical practice. I think with every patient we sit in, we have all the three options and we end up saying, how are we going to choose between them? When we think in the first line setting, they are almost the same. I think it will come down to toxicity, and that's the most important factor. Palbociclib, ribociclib causing much more neutropenia, thrombocytopenia, but again, hardly any febrile neutropenia. With abemaciclib, we have already seen diarrhea is much more common, neutropenia is much lesser. These are kind of regimens we have learned to use with time, and as the new drugs come in, we start using it and we learn better how to use them. So I would say once we've used palbociclib, we are so comfortable with it for so many years, and then ribo came in, we introduced ribo, and now with abema, we are getting comfortable even with abema. So I think it comes down to toxicity, and as previously mentioned in the discussion, again, cost is a major issue. You eventually choose what your patient can pay from your pocket and be able to take it. But I think there are support programs for all three in India, and that's very good that most patients who can extend the treatment can carry on for years and years. That's the best thing about it. Dr. KP showed this, the Parsifal data. The question always comes, if we change the letrozole and move to fulvestrant first line with palbociclib, would that do better? And this was always debated because we always thought fulvestrant may be slightly better than using letrozole. But this data is very good because this information helps us in clinical practice. We can clearly say, no, letrozole, palbociclib, and fulvestrant are exactly the same. And this data is helping us choose and say, it's best to be on letrozole. I don't see any point in putting an IM injection for a patient for years. It's very, very difficult. I think fulvestrant is a very, very excellent drug, but very tough because of the IM injections which you start giving. We have patients on fulvestrant who have crossed many, many years, and it becomes more and more challenging. Patients will start complaining after the second year and third year that why don't you change to oral? And we don't have anything to change to. We say we have to give that IM injection. And you feel quite I would say it is difficult for the patient. An IM injection, both buttocks, goes on monthly. First month, they are very happy because their responses are good. They want to do it and they're very excited. Second year, they start getting a little bit annoyed. By third year, they're really annoyed. They say, this has to stop. This cannot go on. So we have a patient on fulvestrant now for 7 years, and she keeps telling us, this is crazy. How long are you going to keep doing this? And we say, we don't know what to change to. You move through all your chemo or hormonal lines, and this is the one which was working for you for years. We don't want to change it. But this is good data. I feel Parsifal answers that question. Letrozole palbociclib is the ideal first line, and we should stick to that. Another important question, we keep debating, what if we give chemo to our patients? And I'm not talking of patients in visceral crisis. We are saying patients in first line setting when you talk about if you have a patient. So we have data sets to answer, and this is, we saw two data sets. We saw the PEARL study coming out where you use second line patients who had progressed on one line of hormonal, whether you want to go to capecitabine or whether you want to go to fulvestrant palbociclib. And what it taught us was actually there was no difference in the hazard ratio statistically. So it did not matter. You can actually go to fulvestrant palbociclib and keep the capecitabine as a reserve. And that's what this trial showed. But I think the more impressive one is the Young PEARL study, a very difficult and tricky study to do. This comes from China, but if you look at it, it's first line setting. You use premenopausal patients and you do capecitabine versus ovarian suppression with exavestine and palbociclib as first line therapy, trying to answer is chemo better or is hormonal better? And this study was presented in ASCO 2019. So can you imagine, this study has been done in the last few years. Which patient of hormonal would you really give chemo at the present time in such big numbers? So that was very amazing to see. But the data set again is good for us to answer a question. It said that it's better to do palbociclib exemestane with LHRH rather than doing capecitabine first line, and the hazards were statistically significant. 12 months versus 14.4 versus 20 months. So again, we got an answer here. Whenever we say if patient is not in visceral crisis, should we give chemo? I think Young PEARL is teaching us better to avoid chemo and just stick to hormonal therapy with CDK4/6 inhibition. So moving on to second line therapy, second line space is much more complicated space because all the three trials have very different inclusion populations. They're not all the same, and that's why you kind of can't just compare these three trials together. So first was, if you look at hazards again, you'll see PFS hazards are exactly the same, 0.55, 0.59, 0.50 with all the three drugs. But if you start seeing OS hazards, they're different. And that's why one needs to really look into the depth of data, why the OS is different. It's not that one drug is very superior than the other, but we are learning differences. So first is Paloma 3. We saw the overall survival, which was published. Now, if you looked at it, even though you kind of think the hazard was 0.79, it did not meet the statistical boundary. So that's the reason it was not significant. But when they looked at patients who were hormone sensitive and patients who were without sensitivity, when they removed that, we clearly saw the patients who are hormone sensitive, the benefit is there in overall survival with a hazard of 0.721, 29.7 going to 39.7. And if you saw the non-sensitive patients, there was no benefit in the overall survival. So again, it is giving us an indication where we think of using palbociclib in the hormone-sensitive relapse setting. Again, this trial also had patients who had received one line of chemotherapy, which is quite different from the other trials. We saw the Monarch 2 data from abemaciclib, and here again we see very interesting data. The overall survival moving from 37 to 46.7 months, hazards of 0.75. But when you divided them into the primary resistant and the secondary resistant subgroup, here's where you see abema scoring over it. In primary resistant group, your hazard of 0.68, telling you this drug is working even in this primary resistant group setting, 31 to 38 months approximately, but the hazards were significant. Now in the secondary resistance, you don't see a difference yet, but I think that's because you've not had enough events here, because the secondary resistant population really does very well in the long term. So probably the events have not happened yet. But again, clearly a very beneficial drug in this population. And of course, we saw the Mona Lisa 3 data. Again, the same PFS benefits, but the overall survival, 40 months versus not reached, hazards of 0.724 was statistically significant. So clearly showing again, this is beneficial in terms of overall survival also in this group of population. So second line is a very is a different space where we kind of start looking at sensitivity and resistance. If we have primary resistance, a lot of talk is going towards using abemaciclib much more, though there is equally good ribociclib data. Palbociclib is being sort of reserved more in the second line setting for sensitive patients because of the way the overall survival data came out. But again, are this data different due to the design of clinical trials or due to the drugs are different? This is something we'll keep evaluating as time goes. Now, towards the end, I just want to talk about a little bit of the real world experience. We saw the Flatiron data from the palbociclib trials. This was a huge data set where they again did just the patient groups, but then later they did a propensity score matching where they tried to match both the patient groups. And here they saw PFS benefit, again, in the real world setting, hazards of 0.54, exactly the same. And the overall survival benefit, again, 0.58 hazards. So it was significant here in even terms of overall survival in the real world setting with this kind of statistical analysis. There was Indian data of palbociclib, and this is data coming from Dr. Chaturbhuj Agarwal from Delhi. Again, the big data set, 188 patients treated. And what you see is almost the same PFS, what you saw from all the international trials. Median PFS 20.2 months in the first line setting, 12 months in the second line setting, very good impressive response rates of 80%. And again, toxicity being very less, which clearly is what what everyone has seen from the trials also. There was data from many of centers in South India. There was pooled data looking at 5 centers from South India, and this was an initiative done where all 5 centers collated some amount of data and analyzed this. This is an interesting data set again. 133 patients were treated, and again, when we divided them into a first line setting, what we saw was first line settings again doing very well. It's a second line setting. We had a median PFS of 14 months, though there were some second line patients who had actually received chemo and then gone on to second line setting. Again, in the first line setting, de novo patients really did well compared to the relapsed patients. And again, bone mets patients did really well compared to visceral mets. We saw neutropenia in more than 75% of patients, but there was no febrile neutropenia, and that's what makes us very confident of use. So I would like to leave you with this thought. This is where the future is going. We've talked of CDK4/6 with AIs as first line, and that's become standard of care. There is a thought that if you did a SERD, and a SERD may be better than a SERM. So the thought is, if there's a SERD which you can give comfortably, which is not IM, which your patients can take very comfortably, and that's where the oral SERDs are coming in. And you can see 3 new oral SERDs: amcinestrant, giredestrant, and camizestrant. They're going to be much more complicated for us in future. I'm sure in the next 2 years, we'll be debating which of these SERDs is better, just like we were debating which of the CDK4/6 are better. So this trial is looking at amcinestrant plus palbociclib versus palbociclib letrozole. So you're moving your trials to a next level, and this is how it's going to change. I'm sure, look at the size of the trial, 1,066 patients, and it's going to be stratified to everything. It started off also, and we have already seen the amcinestrant data through the Emerald study already in the last year, San Antonio, where it was, I would say, slightly better than fulvestrant in the second line setting. So we have thought maybe it will be a better drug, and let's see how the future goes. So this is how I end. CDK4/6 has changed our clinical practice. We've seen rapid and durable responses. We are very, very confident of using it. We don't offer chemo to any patient. Visceral crisis can be a little bit controversial, and that definition is also changing and evolving. The best thing is we don't get chemo side effects. We have one long duration of therapy on one line, and that matters to patients. We really don't want to keep telling your patients after 6 months, 1 year, no next progress, now we will use the drug. You want to put it up front where they can continue on one drug as long as possible. Our quality of life is excellent. And now we are starting to see the overall survival data sets, and that's again very impressive. Thank you very much.
Thank you, sir. Thank you for showing that detailed evidence for CDK4/6 inhibitors in that situation. Sir, I have a question. What's your experience with abemaciclib? Have you come across any renal failures? Rather raising the creatinine levels?
Yes. So we have used a bit of abemaciclib now in both the second line and the first line settings. We are slowly seeing the difference in the drug. It is definitely different. There's absolutely no doubt about it. Diarrhea becomes an issue. We initially, I think in the last year's initial meetings, we were saying, no, Indians are different. Diarrhea is not bad because all of us had not seen too much diarrhea. But now we have seen enough diarrhea. We have seen patients with severe diarrhea, dose reductions. So there is diarrhea which is very different from it. Even the fatigue levels are a little different in abemaciclib rather than ribo and palbo is what we are seeing. And as you mentioned, we have had a patient whose creatinine went up, and we did exactly what the data said. We stopped it, waited for some time. So the data says you don't need to stop it. You just need to, if it's not too bad. But believe me, my patient's creatinine really shot up hugely. It was not at that level where we were comfortable not stopping it. We stopped it and waited, and it came down. It came down. I haven't evaluated that patient in the sense of doing the testing which they say you should do. we just waited and hydrated the patient, and it was okay. So creatinine is more of a worry in sense of numbers, but not much for a patient is what we are learning. But again, my number is only one where I had it, so I may not be the right person to answer it completely.
Okay, so even I had one patient who had raised in the creatinine levels, and I checked and I went and I did this cystatin creatinine clearance. That came as normal actually. So even I was scared because she was on doctor's mother, so I panicked and I stopped it for a while, and now it has become normal actually.
Yes, absolutely.
So I've restarted her. I will have to see how she does from now on.
Absolutely, yes. So you were able to do the cystatin level. That's good.
Yeah, I got it done.
We discussed about it, but we didn't do it. We eventually said, okay, we'll just wait, and we didn't send it. But that's good to know that you did it.
Yeah, we did it, and it came out to be normal. So I have restarted. So I'll have to see how she does from now on. Thank you, sir. Thank you once again.
Thank you.
Thank you. So with that, I think we'll move on to the next futuristic topic, I would say. Clinical utility of comprehensive genomic profile. Although this topic is, most of us wouldn't do this in routine clinical practice. I think there is now data which would help us consider this in the future. So to listen about this and more, I would like to request Dr. Prasad Narayan, who is a senior consultant medical oncologist at Cyticare Hospital, Bangalore, to present this topic. Sir,
good evening. Thanks to the organizers for this opportunity. So Amit left us with a slide actually, which said that what we are going to have in future. And we all heard the panel discussion by KP, where we are deciding how to use certain drugs in which situation. I will discuss something about comprehensive genomic profiling and what is its role in breast cancer management in the present scenario, with some data on some data which is available. So are the slides visible? Are they moving?
Yes, sir, we can see.
Yeah, fine. So this kind of a slide, I think we see in all cancers in the last 1 or 2 decades, when we see that this particular cancer is not one subtype and then we have multiple groups. The same thing is true in breast cancer as well. But what is more meaningful is that whether these subtypes, for example, now we can say that the genomic driver, genomic classification of breast cancer, we can have pathway-based group like PIK3, AKT, mTOR pathway, the BRCA, the ER signaling, the cell cycle regulation with the cyclin D1, CDK4, and the growth factor receptor pathway. From the talk which we heard before, I think we all know that we have drugs in each of these groups, so it is meaningful. So knowing them actually would make a difference, and that is what I would be discussing, and how to do this and which test we are supposed to do in some situations. So breast cancer, like most of the cancers, has got definitely a heterogeneous landscape, and this actually becomes more complex in metastatic disease, which is also true in other cancers. And in metastatic breast cancer, the ER positive group, specifically, if you see this the slide, we can see that that is the one which looks like there are many options, and that is why we are having different options of treatment which is coming in this group of patients. And just like Amit said in his talk, 5 years of disease control with a new drug in combination with letrozole, I think these things will definitely go more and more, and we will have more and more drugs which will be coming in this group, is what I feel. So this is the a scale of evidence, the ESMO scale actually, about it's just a scale to see what is the evidence for clinical decision making based on the genomic alterations. So this actually classifies the genomic alterations into tier 1, tier 2, tier 3, tier 4, and X actually. The X means that there is evidence to say that this particular drug will not work there, and tier 1 is the best evidence. So as expected, the best evidence lies in HER2 amplification, BRCA, PIK3CA, MSI, NTRK, and the rest of the things are slightly below. And in each group, actually, the SCAT actually gives a B, C kind of an evidence based on the quality of data. So this actually suggests that multi-gene sequencing could provide benefit to patients pending optimal drug access. And most of these are detected by the Foundation 1 test, which is available. let us see the evidence for comprehensive genomic profiling and targeted therapy. So this is one drug which was discussed in the panel discussion by KP. So we know about Alpelisib, and we know that it is it works in PIK3CA mutated patients. So this trial actually is SOLAR-1. If you take the intent to treat, there was not statistically significant difference in outcome. But when you took the PIK3CA group, there was a significant difference. The curves are widely separated here. The PFS is improved. And this actually has given us an opportunity to treat patients who progress with CDK4/6 plus AI in the first line. And we are all doing PIK3CA in most of these patients, and a liquid biopsy actually detects this. So definitely one of the pathways which can help us to decide a particular drug which will help to improve the outcome of these patients. That is one. That is about the SOLAR-1 trial. We have all heard about the ESR1 mutations. So when you see this, the ESR1 mutation is basically one of the mechanisms of resistance to endocrine therapy. And the mutations actually increase with from the primary to the metastatic to pre-treated metastatic. So that is how the mechanism of resistance mutations evolve. And to detect that, definitely we need to do a genomic profiling, or at some point of time in some patients to see whether, say, certain drugs can be used. Whether this will translate into a treatment. This trial, which looked at dexamethasone as a standard of care versus fulvestrant, the ESR mutant patients clearly had a different outcome with fulvestrant. So this trial actually helped us to decide on using fulvestrant versus dexamethasone in a particular group of metastatic patients. And this again is in the group which is ER positive. So that again underscores the point that ER positive HER2 negative group might be the ones where we will be using more and more genomic alteration based treatments. This is when we say that we go to the difficult part of the metastatic breast cancer, that is a triple negative breast cancer. The moment we say triple negative breast cancer, we usually start and end with chemotherapy. But that is not the case now. We have the data from the PARP inhibitors. Now we have the data from some other group of drugs, the AKT targeted therapies. So two different trials looking at the same pathway, the same comparator arm, and similar kind of patient profile. The LOTUS and the PACT trial, they included actually comprehensive genomic profiling on the tumor tissue to allow retrospective analysis by biomarker status. The LOTUS actually tested the PTEN status by IHC as well. PFS was the primary endpoint. What are the results like? So both the LOTUS and the PACT trial, if you see in the entire population, if you see, there is slight difference. The hazard ratios are similar in showing some benefit of the drug as compared to paclitaxel alone. But when we go to the specific biomarker-based analysis, which is the PIK3CA, AKT1, PTEN altered population, the PACT trial, the hazard ratios are widely different. The graphs are, this is very small number of patients, but this is how science progresses as we know. So this trial tells us, this phase 2 trial told us that we have to look at this group of patients, and a biomarker selected TNBC treatment, a larger trial is required actually, which is very, very promising in triple negative breast cancer. Similar outcome from the LOTUS trial. Again, when you take the pathway based treatment, there is a much different outcome for these patients. So both these trials put together gives us an opportunity to look at this group of patients and try to use a targeted therapy along with chemotherapy in these patients. So from the ER positive, HER2 negative group to the triple negative, now we go to the HER2 amplifications. When we talk about HER2 amplifications, when we do a comprehensive genomic profiling, we will get the HER2 amplification results. Does this correlate with IHC and FISH, which is the standard which we do? So there is a 98.1% concordance and 99.3% concordance in an independent set, which is pretty good actually. So when you do a comprehensive genomic profiling, just like when we talk about lung cancer, where we do a NGS at the first line, because now we have more and more mutations and target therapies available. Maybe in future, we will be doing similar kind of test in breast cancer patients in metastatic disease to choose what is the line of treatment we are going to give. Having said that, there are certain things which is more than the standard IHC and FISH. So this trial, an interesting trial actually, the Summit trial actually, looked at the HER2 mutant tumors, regardless of the histology. And it looked at the mutation specifically. Predominantly, there were SNVs and insertions, and the effect of giving niraparib in these patients. So in breast cancer patients, neratinib in these patients, the breast cancer patients, the response rate was 32% at week 8. So that is significant, similar. And these variations, the mutations actually occur in 7% of the patients who have HER2 amplified metastatic breast cancer and 3% of the patients who have HER2 negative breast cancers. These are undetectable by standard of care tests like the FISH or the IHC, which is important. So we can get some patients who may benefit with neratinib treatment by doing a mutation analysis. Is there? Okay. So when we take this to the next level, the MUTE-HER trial actually looked at neratinib plus fulvestrant. Can I get? I'm hearing something which is disturbing actually.
You please mute others.
Okay, fine. So the MUTE-HER trial, somebody should mute the background noise also. The MUTE-HER trial actually looked at fulvestrant plus neratinib in active, heavily pretreated ER positive HER2 mutant metastatic breast cancer. So this trial selected patients based on HER2 mutation and not the standard HER2 IHC or FISH. If you take this trial in full, this trial is a negative trial because the trial had a primary endpoint of clinical benefit ratio and it did not meet the predefined efficacy criteria. But definitely there is a activity which is shown in the trial, and that is how trials move or the drugs move from later lines to the previous lines. I think there is a parallel.
Yeah, just technical team, you're requested to mute somebody.
If I am audible enough, I can continue.
Please mute that noise, no?
Fine. So we all know about BRCA testing. I also mentioned briefly in the about triple negative breast cancers. So BRCA testing, from our ovarian cancer experience, we know that germline BRCA is not the only thing, and somatic BRCA, then the HRD, all these are group of patients where we can give targeted therapy and PARP inhibitors. So the data in breast cancer in this group of patients is evolving, but definitely there is a role of an extended BRCA testing, and that is best done when we do a comprehensive genomic profiling. So PARP inhibitors nearly double the progression-free survival versus chemotherapy in BRCA altered patients. When I say BRCA altered, it could be a germline or a somatic or an HRD. And the best way to do again will be a genomic profiling of these patients, which will also give us other information. So that is another pathway which can be detected by using a comprehensive genomic profiling. What about other drugs which are not available to us or which we discuss mostly in our meetings? The FGFR inhibitors. They are under investigation in solid tumors and in breast cancer as well. So amplifications are the major source of FGFR alterations in breast cancer. These are trials, phase 1 and 2 phase 2 trials, which have looked at FGFR altered breast cancer patients and targeted therapy in them with reasonable response rates and reasonable progression-free survival, whether with fulvestrant, when an FGFR inhibitor is given, the progression-free survival almost doubled actually. So definitely something to look at, another pathway to be explored. Then the usual mutations which we see when we do a comprehensive genomic profiling, we may get a TP53, an RB1 or NF1 mutations. Mostly, we don't have any targeted therapy based on that, but they have prognostic significance. If you see the overall survival of TP53 altered metastatic hormone positive HER2 negative breast cancer, it is hugely different. The patients do worse if you have a TP53
Apologies,
alteration.
sir, you are just left with 2 minutes to conclude your presentation. Thank
Sure,
you.
I don't need 2 minutes actually. So we will just discuss about liquid biopsy. Liquid biopsy in breast cancer can be done in other solid tumors as well. When we do liquid biopsy, it is sometimes when we don't have a solid biopsy to be done, or when we have to monitor a response. And liquid biopsy has come big way in breast cancer. The PIK3CA mutations we are doing by liquid biopsy, and we have data of liquid biopsy in all types of breast cancer. So this is a trial which actually aims to use the liquid biopsy to match breast cancer patients to different targeted agents. So the ESR1, the HER2 mutation, the AKT1, in all these pathways have a targeted therapy to be tested. So, and some of the early data actually suggests that a liquid biopsy based treatment actually makes a difference. So I think that is what I have in the study. I have given you 1 minute back actually. Thank you.
Thank you for thank you for saving time for us, sir. Thank you for having you this evening. And I think you've showed us some of the important newer aspects in molecular oncology as far as breast is concerned, particularly in advanced breast cancer. Although we would resist at this point of time to those tests, I think so in time to come, we would be considering doing these tests as we get more and more drugs available and gets approved in this situation. Thank you, sir. Thank you once again for your wonderful presentation. Now we'll move on to the next topic. I think we'll shift gaze from very futuristic and advanced topics to routine and mundane topics. So now we will listen to neoadjuvant therapy deep dive. So to talk on this, I request Dr. Sai Vivek, who is a consultant medical oncologist at Sri Shankara Cancer Hospital, Bangalore, to present this. Dr. Sai, over to you.
Good evening all. Am I audible? Good evening all. Are my slides visible?
Yeah, we can see your slide and we are audible.
Yeah. Firstly, I would like to thank Dr. Vivek sir and Dr. Rahul sir for giving me this opportunity. And without wasting any time, so why do we use neoadjuvant therapy? So this is an age-old question. So firstly, for breast cancer patients who definitely cannot be operated, that is the inflammatory and other inoperable case scenarios, and also to make BCS more feasible and reduce the complications of surgery, and also reduce the need for revision for residual tumor. Now, when HER2 positive breast cancer patients, after the Catherine data, we have response adjusted therapy or response adapted therapy, where people who do not achieve a PCR and with a significant residual cancer burden, especially graded by the RCB grading, will definitely benefit from adding TDM1 in the adjuvant setting. And it has clearly showed by reducing the invasive breast cancer disease-free survival by around 50%. Also, we have proved beyond doubt with multiple meta-analysis, especially the one published in JAMA in 2016, where more than 5,000 patients across multiple studies were evaluated, which shows that PCR can be taken for long-term clinical benefit, especially in HER2 positive and hormone negative setting, where there's a 50% reduction in the risk of disease recurrence. And in the hormone setting, it's around 30 to 40%. Yeah, so I was just talking about the CT-NEO-BC is another meta-analysis when an international working group known as the Collaborative Trials in Neoadjuvant Breast Cancer was commissioned by the FDA to investigate PCR as a surrogate endpoint for long-term outcomes. And the CT-NEO-BC also included triple negative breast cancers, but there was another analysis published in JAMA, which mainly concentrated on HER2 positive. And so this proves that PCR, which is commonly used in most of the neoadjuvant trials as an endpoint, could be actually true and to predict long-term clinical benefit. So now I'm going to talk about two trials which have used dual HER2 blockers in the neoadjuvant setting. Both are phase 2 trials. One is the NEOSPHERE and the other is the TRIFINA study. And the primary endpoint of both the trials are different. So while PCR was the primary endpoint of NEOSPHERE, Trifina actually studied the tolerability and safety of using dual HER2 blockade with chemotherapy. And jumping on to Neosphere trial, it was a phase 2 trial where 417 patients were randomized to 4 arms. The first arm being Herceptin plus docetaxel, the second arm being Perjeta, Herceptin plus docetaxel, third arm being pertuzumab plus Herceptin without any chemotherapy, plus docetaxel without the pertuzumab. And after this, patients underwent surgery and all of them received adjuvant anthracyclines along with trastuzumab. So the key eligibility criteria that was used was operable, locally advanced or inflammatory breast cancer, which were HER2 positive by the CAP criteria, no metastatic disease or bilateral breast cancer or any other malignancy other than cancer in situ of the cervix or basal cell cancer, no previous anti-cancer therapy or radiotherapy for any malignancies. And the primary tumors had to be more than T1, more than 2 centimeters, and no cardiac dysfunction or even insulin-dependent diabetes. So what they definitely found was dual HER2 blockade was associated with higher PCR rates. It was 45.8% where pertuzumab, trastuzumab, and in the docetaxel arm. And the 5-year DFS data also showed that with usage of dual HER2 blockade, the 5-year PFS was much better. So was the DFS. And coming to the most important thing, we are using 2 HER2 blockers. What about the safety? What they found was the safety across all the groups were comparable. In fact, the trastuzumab and docetaxel arm had more neutropenia compared to the dual HER2 blockade. And even in the adjuvant setting, when trastuzumab was used along with FEC, also the adverse effects were quite comparable. So this did not show up any new red flags. So they summarized that a PCR rate of 45.8% versus 29% with dual HER2 blockade versus using only trastuzumab respectively. Substantial anti-tumor activity and a favorable therapeutic ratio for trastuzumab and pertuzumab doublet without chemotherapy, but patients here received the taxane and anthracyclines in the adjuvant setting in this arm. But we all know HER2 positive breast cancer is biologically more aggressive. So initially, historically, we know that chemotherapy definitely does well when used in HER2 positive. So the whole concept of avoiding chemotherapy, unless in a case-to-case basis where patient is definitely medically unwilling or medically not fit for giving chemotherapy, we usually don't avoid chemotherapy. Pertuzumab and trastuzumab without chemotherapy also eradicated tumors, but that is not followed routinely. No meaningful increase in cardiac risk with pertuzumab over a short course of 4 cycles of neoadjuvant therapy was seen. So this was a phase 2 trial. Coming to the other trial, which is a Trifina trial, where again, the primary endpoint here was the safety and tolerability of neoadjuvant treatment, especially the cardiac safety. The secondary endpoints being PCR, DFS, OS, and other biomarker evaluation. One thing which is important with this study is this evaluated a anthracycline-free regimen in terms of pertuzumab plus trastuzumab plus docetaxel and carboplatin given for 1 to 6 cycles. The other 2 arms were pertuzumab, trastuzumab plus FEC, followed by docetaxel plus the dual HER2 blockers. And the other arm being only anthracyclines followed by dual HER2 blockade plus docetaxel. So this was mainly done to evaluate the cardiac safety as the primary endpoint. And patients after surgery were allowed to complete Herceptin up to a total duration of 1 year. So what did they see? The eligibility criteria was the baseline characteristics were generally balanced between all the treatment arms. And one thing to note here was there were slightly less patients with ER positive and or PR positive tumors in arm B, and there were slightly more patients with HER2 positive IHC 2+ tumors in arm A. The third point is what is important. The proportion of patients with operable breast cancer was lower in arm C, that is the anthracycline-free arm. Correspondingly, more patients in this arm presented with locally advanced disease. So we are treating a locally advanced breast cancer with an anthracycline-free regimen. And what they found was the side effects, which was the primary endpoint, was actually not very different in the neoadjuvant setting. But what I would like to point out here is in the adjuvant period where the patient is receiving only Herceptin or trastuzumab, they found the LV decline of more than 10% from baseline to less than 50% was almost double in the arm B, where they used FEC3 followed by dual HER2 blockade, and compared to the other two arms, which is quite surprising, where though the dual HER2 blockade was used with anthracyclines in arm A, the difference was seen more in the arm where anthracyclines was not compared. So with this, we could say, though we don't routinely use it in a setting where we have to, we can actually combine it with anthracyclines. So the PCR rates were higher in arm A and arm C, where pertuzumab and trastuzumab were given for 6 cycles before surgery. So that could be the reason why the PCR rates are higher in arm A and arm C. And the DFS were nothing much to choose here. So all the 3 arms had actually showed a median DFS of 87, 88, and 90% at the end of 3 years. But that was in the primary endpoint here. And OS also is almost similar across all the 3 arms. So they summarized that a low incidence of symptomatic neoadjuvant and adjuvant periods. So concurrent administration of pertuzumab plus trastuzumab with epirubicin resulted in similar cardiac tolerability compared with sequential administration or the anthracycline-free regimen. Neutropenia, febrile neutropenia, and leukopenia and diarrhea were most frequently reported adverse effects across all arms. So regardless of the chemotherapy chosen, the combination of pertuzumab with trastuzumab in the neoadjuvant setting, especially if given for more than 4 to 6 cycles, definitely increase the PCR with just trastuzumab alone. So we know with chemotherapy, we hit almost around 25 to 30%. With trastuzumab, it goes up to 45. And with dual HER2 blockade, we can achieve a PCR of up to 60%. And taking that PCR and translating it into a meaningful clinical benefit to our patients has already been established. So in especially patients with more than 2 centimeters or lymph node positive breast cancers, we have to, I think, with this data, offer dual HER2 blockade to patients who can actually take it. And that's what the NCCN also says. So though it also recommends only trastuzumab with carboplatin and docetaxel, dual HER2 blockade and the taxanes and carboplatin is also an acceptable regimen. Thank you.
Thank you, Dr. Sai, for taking us through that evidence of anti-HER2 therapy data. So you have very clearly elucidated on the evidence, and we have seen in the real world also that these anti-HER2 therapies, particularly in combination, have made a huge difference to PCRs, and we can see that outcomes. Thank you very much once again. So from neoadjuvant, I think we'll move on to the adjuvant treatment of HER2 positive breast cancer. So to talk on the role of Kadcyla in adjuvant treatment of HER2 positive early breast cancer, I would like to request Dr. K. Govinda Babu. Sir.
Thank you, Vivek, for asking me to talk about this.
I was wondering whether you were there or there were any last minute changes. So
no, Vivek, after agreeing to you, I can't change.
My privilege to all our privilege to have you, sir.
Thank you.
Thanks, sir.
So that talk from Vivek was nice, and he has already laid the foundation about neoadjuvant. So I'm going to talk about the role of HER2 targeted therapy in adjuvant breast cancer. I'm sure you all recognize this slide. This is about how we divide time as BC and AD. And you must be wondering why I'm showing this. So this BC and AD with respect to breast cancer can be converted into BT and AT, by which I mean that we understood the HER2 pathway and we got this drug called trastuzumab. So that is why BT and AT. This has actually transformed the way we look at HER2 positive breast cancer patients. And we know that one point of time, this was a poor prognostic factor for breast cancer. But because of this particular drug, we are now converted this poor prognostic HER2 positive breast cancer into a good prognostic one. So this is just the timeline of anti-HER2 therapies that have evolved over time, and I won't bore you with the details here. So today we know that Herceptin, as it was marketed, is the foundation of care for women with HER2 positive breast cancer, be it early or metastatic. And as you know, most of these new drugs first start with metastatic disease and then percolate down into early breast cancers, neoadjuvant and adjuvant. So TDM1 we're talking about is the Trojan horse concept. I'm sure all of you know about this Trojan horse. So in early breast cancer, the goal of treatment is cure. And therefore, the patient should be given the most efficacious treatment available. But we know that up to 78% of early breast cancers relapse. And this is a significant number. And at present, currently, there is no cure for HER2 positive metastatic breast cancer. Again, it depends on how you actually define cure. So I will not 100% agree with this particular statement. So neoadjuvant therapies, Dr. Sai has already told you all the benefits. This is talking about early breast cancer management. I think the most important as a medical oncologist is that this offers a window of opportunity for you to study how your tumor is going to respond to the therapy that you've given. Also, it enables response assessment, which I mentioned, enhances surgical options, and early institution of systemic therapy. You already heard about the NeoSphere study, and this is again showing you the same slide with different colors, talking about the complete pathological response, and dual HER2 blockade offers the best one. So I think this is just the recap of those data that is already there, NeoSphere and Affinity. And for NeoSphere, we have a 5-year disease-free survival, and for Affinity, we have a 6-year disease-free survival, and both showing benefits. But we must remember that there is residual invasive disease present in almost 40 to 60% of these patients, in fact, of receiving dual HER2 blockade neoadjuvant therapy. And that is shown in both the NeoSphere and the Trefina studies. Now, despite the proven benefits, we know that these patients who have a residual disease are at a higher risk of recurrence. So as I mentioned, 40 to 60% of patients will have residual disease, and patients with residual disease have a greater chance of recurrence. So it's important to adapt early breast cancer treatment to avoid recurrences, which may progress to incurable metastatic breast cancer. So we have this data of tailoring adjuvant therapy after neoadjuvant from the CreateX for TNBC and Catherine trial. So today what I'm going to discuss is this Catherine study. And this is the actual concept of this study, that once there is neoadjuvant therapy instituted, surgery is done, and then you access and assess the residual tumor and then take a decision as to whether you're going to continue the same neoadjuvant that you're given, or when there is residual disease, you're going to shift them into the TDM1. So prior to Catherine's study, there was no data available to guide this particular treatment decision for us when there was residual disease present in the resected specimen after neoadjuvant HER2 blockade. So CreateX, this is of course in the triple negative breast cancer patients who benefited with the addition of capecitabine in the adjuvant setting. In the metastatic setting, we know that Kadcyla or TDM1 has activity in patients who have progressed after chemotherapy and HER2-directed therapy, including those patients who have relapsed within 6 months of treatment. And this is important because this is a sort of a indicator of the aggressiveness of the disease. And therefore, this study was designed, the Catherine study was designed to provide evidence for optimizing the therapy in these patients with early breast cancer who have residual invasive breast cancer or in the axilla following neoadjuvant Herceptin containing therapies. So this is the study design. T1 to T4, N0 to N3, M0 at presentation, T1A, T1B were excluded and N0 were excluded. HER2 positive early breast cancer, neoadjuvant therapy, minimum 6 cycles of chemotherapy, minimum 9 weeks of taxanes, anthracycline and alkylating agents were allowed. all chemotherapy prior to surgery, minimum 9 weeks of trastuzumab, and second HER2 targeted agent was also allowed, and residual invasive tumor in the breast or axillary. And then they underwent surgery. They looked at the evidence of residual disease, and they were randomized into the two arms. The stratification factors included clinical stage at presentation, inoperable versus operable, hormone receptor status, ER/PR positive or negative versus positivity, and neoadjuvant HER2 directed therapy, whether it was a single agent Herceptin or dual HER2 blockade, and the pathological nodal status, which was evaluated after neoadjuvant therapy. The primary endpoint was the invasive duct-free survival, with secondary endpoints that included DFS, OS, and DFI, and of course, the safety part. So these were the primary endpoints which I've already described. What constituted IDFS was the ipsilateral invasive breast cancer tumor recurrence, ipsilateral local regional invasive breast cancer recurrence, distal recurrence, collateral invasive breast cancer, death attributable to any cause, including breast cancer, non-breast cancer, or unknown cause. And the secondary one was IDFS, DFS including primary non-breast cancer, contralateral or ipsilateral DCIs, overall survival, DRFI, cardiac safety, overall safety, and patient-related outcomes. The inclusion and exclusion criteria typically for such a study, I don't need to go over for audience of this type. So the study population, 743 patients here, well balanced, treated also, median duration of follow-up 40 plus months, crossover from Kadcyla to Herceptin. This did not happen, but in the Kadcyla arm it was allowed, and the statistical power for us to understand what is the significance of using Kadcyla here. So the primary efficacy endpoint was shown here. What exactly was seen was that the lower pathological complete response for patients with hormone receptor positive disease meant that Catherine population was enriched in this group. So that is why they actually looked at categorizing for receptor positive, that is the estrogen and progesterone receptor positivity or not, and they looked at whether there was difference in these groups or not with the neoadjuvant therapy. So this is again showing you that they were well matched for age. They looked at less than 40, more than 65, and in between, race, white, Asians, and the other groups, region-wise, North America, Western Europe, and rest of the world. So they were well matched for that. And this is looking at the extent of residual invasive disease, including pathological nodal status at the time of surgery. And this was again well matched between the two treatment arms. What this analysis showed was that there was more than 40% of patients who had only small amount of residual tumor disease present after neoadjuvant therapy. So this is looking at the prior therapy. I already told you the sub-stratification that they made based on the different types of neoadjuvant therapies that were given, and they were well matched in these two groups. And approximately 18% of patients had received prior Perjeta and Herceptin as neoadjuvant therapy. So this is looking at the primary endpoint, which is the risk of IDFS. And what was shown was that at the median follow-up of 41 months, the decrease was a staggering 50%. And this is at a 3-year follow-up. And you can see that the follow-up is almost for 60 months, and these two curves are evidently separating out. So that is the advantage of using Kadcyla in these patients who have residual tumor after the neoadjuvant therapy. The magnitude of IDFS benefit for all subgroups was consistent with the intent to treat population included across all stratification factors. So I already told you about various groups that they looked at, and they found that this was significant in whichever group you were analyzing the effect. So the magnitude of IFS benefit in all subgroups, as I told you, was evident, and the benefit was consistent irrespective of the tumor size, nodal status at surgery, including patients with residual tumor less than 1 centimeter and who are node negative. So even in very small tumors and nodes being negative, the benefit was seen. So this is looking at secondary endpoint, which is distant recurrences. And again, the arm that got Kadcyla showed that there were fewer distant recurrences as compared to the Herceptin alone arm. And as you can see, the hazard ratio is 0.60. And again, here the follow-up is for almost 60 months. This is looking at the other secondary endpoint, which is overall survival, which as medical oncologists, we are always harping on, looking at overall survival. This is the first interim analysis. And therefore, as you can see, there is a difference, but still it's not statistically significant as of now. Not greatly statistically significant, but I think over a period of time, especially because this is in the adjuvant setting, we need to wait longer. But the hazard ratio, as you can see, is 0.70. Now, efficacy, I think we have all used Kadcyla before, and we're quite familiar with this. And this study showed that there were no added side effects, even in the adjuvant setting. So the efficacy was maintained across the key secondary endpoints. And as I mentioned, the overall survival, which we always wish is significant as medical oncologists. So the safety data primary analysis, they looked at the 14 cycles of completion, and they found that similar proportion of patients completed 14 cycles. And if you can look at the dose reduction, not applicable for trastuzumab. And this was pretty clear that Kadcyla is a safe drug, even in the adjuvant setting, up to 14 cycles as well. This safety data, again, is consistent with the known safety profile of Kadcyla, which I already mentioned. And this is showing you the various ones, starting from fatigue, nausea, platelet count, liver function tests, headache, arthralgia, radiation, skin injury, and the other things like epistaxis, sensory neuropathy, etc. And what conclusion was that these Kadcyla-related AEs were generally of low grade, manageable, and easily monitored. And as I mentioned, most of us have had experience with using Kadcyla in the metastatic disease, and therefore it shouldn't be a problem for using it in the adjuvant setting as well. So to summarize, Catherine has introduced a new decision point in HER2-positive early breast cancers. Adjuvant treatment should now be based on the response to neoadjuvant therapy. And this is one of the forms of tailoring adjuvant therapy now. And as I mentioned, they should receive 14 cycles of Kadcyla in the adjuvant setting. This is a recommendation of the international treatment guidelines. And patients who achieve pathological complete response after HER2-directed adjuvant therapy still have a risk of relapse. And therefore, they must continue the dual HER2 blockade to 18 cycles in the adjuvant setting. So with this study, Catherine marks a new standard of care for patients with HER2-positive early breast cancer. And this is all the summary of this study. With that, I think I will stop, and thank you very much.
Thank you, sir. Thank you very much for that very clear and elaborate presentation on the evidence of anti-HER2 therapy in the adjuvant situation for these difficult to treat subset of patients who have residual disease after neoadjuvant therapy. When this data came out, I had to think like, we are using up all the anti-HER2 therapies which are available for this group of patients, and what do we offer after this? But looking at the, that beautiful data, I think there is nothing to hold us back from, adding this particular injection later on, I think. So thank you very much, sir. So,
thank you, Vivek.
So from that, I think we'll move on to the next topic, which is difficult to treat subset of CA breast patients who are triple positive. So for various reasons, I think these are very difficult patients for us, that too in a metastatic situation. So to speak on this particular topic, non-chemotherapy options for management of metastatic triple positive breast cancer, I would like to welcome Dr. Venkatapradeep Babu Koyala, who is Assistant Professor of Medical Oncology at Homi Bhabha Cancer Hospital, Visakhapatnam, Andhra Pradesh. Dr. Venkatapradeep, over to you.
Good evening, dear colleagues and respected seniors, and thank you, Dr. Vivek and Dr. Sood, for giving me this opportunity. Vivek sir, I have moved on from Homi Bhabha to Assam Cancer Care Foundation, a Tata Trust operation.
We'll get updated on that. Thank you.
Sure, sir. No problem, sir. So For the next 15 minutes, I will take to the data that is available on the non-chemotherapy options in advanced triple positive breast cancer. So when we see the breast cancer subtypes, 3 groups are really distinct based upon presence or absence of these hormone receptor and HER2 receptor. By the absence is triple negative breast cancer subset, and by the presence is the HER2 positive subset. But there is a subset that is in between, that is hormone positive and HER2 positive. So do we need to recognize this as a different subtype and treat differently? As of now, till now, as per the data and for the clinical trials, we are including it as a part of HER2 positive and treating accordingly. So we all know that HER2 positive breast cancer is not really a unique entity. The heterogeneity of HER2 positive breast cancer arises from the presence or absence of the hormone receptors and variability of its percentage of expression. So the differences in the clinical behavior, treatment sensitivity, and intrinsic biology, we know and we daily see in the clinical practice when the hormone receptor is negative and positive. And almost all HER2 positive patients as of now are being treated as a singular entity, both in early stage as well as advanced stage, particularly in the setting of clinical trials. So attributing lesser significance to hormone receptor in HER2 positive, is it acceptable or not? Let's see what data shows for us. So the optimal management of triple positive breast cancer, it lies somewhere on the border between the pure endocrine therapy and pure HER2 targeted treatments. By majority of the patients are being treated by a combination of chemotherapy plus trastuzumab, depending upon the disease burden. So is there a middle path where we can avoid chemotherapy, which the patient craves through for not having chemotherapy, and we can proceed with the non-chemotherapy options? Let's evaluate. Before going into the data, let us see whether there is a mutual influence of hormone receptor and HER2 on each other. Definitely yes. There is a crosstalk between hormone receptor and HER2 positive family receptors. Whenever there is a anti-HER2 administered to in the breast cancer cell, there is a reactivation of estrogen receptor signaling as a mechanism of resistance. And we all know that the Ki-67 or proliferative index is relatively higher in HER2 positive cancers when hormone receptor is positive compared to the HER2 negative. So this is the influence the hormone receptor and HER2 have on each other. What are the opportunities we have to personalize therapy in advanced disease setting, particularly in triple positive breast cancer patients? Let us see whether we can get a better result by targeting HER2 arm or hormone receptor arm. So the initial studies I am going to take through to the single agent HER2 blockade along with hormonal therapy. So this is a study which is showing the results of trastuzumab plus hormonal therapy. And the point to take away from this slide is that as the percentage of ER expression increases, when it is greater than 30%, the results of the trastuzumab plus chemotherapy decreases. We can see here in this graph, the PFS, whenever there is in the solid line indicates the estrogen receptor greater than 30%. So the PFS decreases gradually, but in those subset with ER less than 30%, the PFS is definitely better. In those subset where ER and PR both are greater than 30%, we can see the PFS line, it touches the x-axis, showing that the chemotherapy is not doing really good along with trastuzumab in this particular subset where the hormone receptor expression is greater than 30%. One more point to take away from this study is that in those patients who have completed trastuzumab plus chemotherapy in a metastatic setting, the patient who has received the hormone receptor, hormone therapy as a maintenance, they have less PFS events compared to those who have not received any anastrozole or letrozole maintenance. You can see nearly the 24% difference in the PFS events in those who received and who do not receive the maintenance. So this is the trial which is showing the combination of trastuzumab plus anastrozole versus only hormonal therapy, that is anastrozole plus placebo. The primary endpoint is PFS, which is achieved in this study, and 4.8 months in the trastuzumab arm compared to 2.4 months, almost double the PFS by combining trastuzumab and hormonal therapy. Similarly, letrozole plus trastuzumab compared to letrozole, nearly in 1/4 of patients, it was seen that the patients performed better for at least 1 year. But at the same time, in this subset, where combination of trastuzumab and single agent letrozole, nearly half of the patients, they do not have responses, or they do not respond to this combination. Maybe we need a better patient selection to see actually where this combination works. So this is the similar trial, ELECTRA, combination of letrozole plus trastuzumab versus letrozole alone. Although the PFS is really benefit in terms of like time to tumor progression, it is 14.1 months compared to only 3.3 months with letrozole. The OS data is not available for this trial for the reasons unknown. Other HER2 agents that were tried in combination with letrozole were lapatinib. So lapatinib plus letrozole versus letrozole again. 8.2 months in the lapatinib arm versus 3 months in the letrozole arm. The primary endpoint is PFS and it is achieved in this subset. So can we achieve better results by targeting more HER2 with a better HER2 agents? So this is the trial, PERTEN trial, which looked at the same concept of targeting HER2 in triple positive breast cancers in advanced settings, where trastuzumab along with aromatase inhibitor with or without pertuzumab is tested. We can see here the primary endpoint is PFS, and it is achieved in this trial with a difference of 3 months in the difference in the PFS. And when we see the hazard ratio, nearly 35% of events of PFS are prevented by combining pertuzumab in this study. There is alternative trial where double agent HER2 agents were tried along with the aromatase inhibitors. So in this alternate trial, this is a second line trial. There are 3 arms where lapatinib plus trastuzumab plus aromatase inhibitor is the primary arm of interest versus single agent HER2 blockade by trastuzumab plus hormone therapy, and lapatinib plus hormone therapy. When we see the results of this trial, the triple agent arm did much better, followed by lapatinib plus aromatase inhibitor, followed by trastuzumab plus aromatase inhibitor, which is really interesting that lapatinib did much better than trastuzumab. So can we combine even more better agents in the triple positive cancers? Let us have a look at the early local advanced breast cancers. Frankly speaking, there are no separate trials in this group. But when we see the Catherine study, which Dr. Govind Babu sir has elucidated clearly in this in the previous talk, there are 72% of patients who are hormone receptor positive, which means triple positive in this setting. And when we see the IDFS rate, which is one of the endpoints of the study, in the TDM arm, it is definitely beneficial in terms of IDFS 3-year IDFS rate in the triple positive arm with TDM1 compared to trastuzumab alone, proving that the better the targeting of HER2 agents, the benefit it may be more beneficial. But when we come to the advanced setting with the same agent, that is TDM1 in the Emilia trial, where TDM1 was tried against LabCap in the second line setting, nearly 57% of patients, they are triple positive in this trial, and 41% of patients, they have received prior endocrine therapy. And if we see the PFS and OS subset analysis from this trial, we can clearly see that TDM1 fared much better in terms of PFS of 9.6 months versus 6.4 months with the LabCap arm. When we see the overall survival, it is statistically significant difference of 30.9 months survival with the TDM1 versus 25 months with the LabCap arm in this triple positive breast cancer subset. Now the question comes, if we target more the hormone positive arm, can we achieve much more better results? Because we have much better agents to target the hormone positive cancers in terms of in the form of CDK4/6 inhibitors. The trial, this is one of the late breaking abstracts that is presented this year, which is MONARCH-HER trial. This is a phase 2 study which has looked at combination of abemaciclib plus trastuzumab with or without fulvestrant versus only trastuzumab plus standard chemotherapy. When we see the statistically the efficacy analysis, definitely the abemaciclib arm, it has done much better in terms of 8.3 months versus 5.7 months. So this forms effective non-chemotherapy option in patients who are seeking for non-chemotherapy options in triple positive subset in advanced setting. There is one more interesting abstract that was presented in the combination of CDK4/6 inhibitor plus AI plus trastuzumab. This is the palbociclib, the agent which is used in here. But they have stratified this hormone positive patients by using PAM50 luminal intrinsic subtype, and they clearly defined which are really hormone positive or not by using this microarray of PAM50. When we see the first safety run analysis, that was the final analysis data is not available in this study, but when we see the first safety run analysis, it is proved that it is safe and active in this subset, palbociclib arm along with aromatase inhibitor. Also, this paves the path for the better stratification and better selection of patients when we use costly therapies like CDK4/6 inhibitors by using the molecular stratification like PAM50, where we can get a better results by selecting the exact hormone positive patients. So coming to the conclusions from these trials, there is a substantial lack of specific trials in this triple positive subset. And we know that a majority of HER2 positive tumors, they are excluded from the endocrine trials, and the HER2 targeted agents often done the analysis without seeing for the hormone positive and hormone negative as a pre-planned analysis in majority of the trials. But we can see that increasing evidence that there are differences in the outcome between two subsets of hormone positive and hormone negative HER2 positive cancers. This is the summary of the triple positive breast cancers. Various agents used, which we already discussed in the first line and second line. Whenever we target the HER2 compared to aromatase inhibitor, and they are definitely doing better. The PFS is better. And when we combine trastuzumab and pertuzumab, and when we use the more potent HER2 agent, the PFS is much better. We can see here in the PERTEN trial, the PFS is 27 versus 15.1 months only with the trastuzumab. In the second line, we have already discussed the alternative trial where the triple agent of trastuzumab, lapatinib, and aromatase inhibitors is done better, followed by lapatinib plus AI, followed by trastuzumab plus AI. But the interesting combination will be where we can actually combine these CDK4/6 inhibitors along with the potent HER2 agents like pertuzumab, tucatinib, and neratinib. These are the ongoing trials in the same lines where we can see that after 2 or more lines, the endocrine therapy is being combined with the ribociclib, palbociclib, and along with the trastuzumab and pertuzumab. The results can be quite interesting with much more benefit in this particular subset. There are other trials which are testing pyrotinib, tucatinib, as well as neratinib in the same lines. With this, I conclude my talk, and thank you so much.
Thank you. So thank you, Dr. Pradeep Babu, Venkat Pradeep Babu. So for that difficult to treat subset of patients, treatment options for us. Hopefully, we will have more data and more drugs for these subset of patients in the future, so that we can treat them efficiently. Thank you, sir.
Thank you.
So with that, I think we will move on to the next important topic of today's session, that is SABC updates of 2021. So to talk on this topic, immune checkpoint inhibitors used in breast cancer. So key takeaways from this recently concluded SABC meeting. I would like to request Dr. Bharat Vaswani, who is a senior consultant medical oncologist at Yashoda Hospital, Hyderabad. So over to Dr. Bharat Vaswani.
Good evening, sir. Am I audible and are my slides visible?
Yeah, you're audible, and we can see.
Let me thank the organizer, Dr. Vivek and Dr. Rahul, for a wonderful conference. Really enjoying it. And I'll have to thank Tarun also for allowing me. He gave me the password to go through the entire SABCS. So I have chosen three oral presentation. 2 of you know, but I think I have to present. There are some new things that I'll be telling that has come. Of course, I have taken the discussion also that were conducted post this. So the topic is what was new in immune checkpoint inhibitor used in breast cancer. What were the main things that came in this SABCS conference? Yeah. So I have tried to divide my topic into neoadjuvant versus adjuvant and metastatic. Now, the first take-home message for a neoadjuvant is immune oncology drug or an immune checkpoint inhibitor are here to stay. Now, these are the 4 pivotal studies. Whenever if there are students, there are sitting, when you talk about neoadjuvant immune checkpoint inhibitor, there are 4 trials that have been conducted, which needs to be discussed, but I will concentrate on the most important study, which was updated, which included pembrolizumab. Please see the number of the patient, 1,174. Though by far the biggest studies in the neoadjuvant setting and adjuvant setting, and there were updates, and it was heartening to see the final outcome. So what was the update? There were event-free survival sensitivity and subgroup analysis of Keynote 522, which combined neoadjuvant pembro with chemo versus placebo with chemo. So newly diagnosed triple-negative breast cancer, a high risk. Please remember the chemotherapy arm which was taken in both. So it included platins plus Taxol followed by AC, and AC was not dosed in. Please remember platins, because that is where one of the advantages is. Combined with pembro followed by pembro post of 9 cycles. The primary endpoint was pathological CR and event-free survival, with secondary endpoint what was mentioned above. Now, when you look into the first primary endpoint, 14% improvement in terms of absolute number in pathological CR. When you look into PD-L1 positive on the right side and a negative, the quantum of benefit remains more or less the same. So around 14 to 18% improvement in pathological CR when you combine immuno. Now, what was heartening, and I think the most important thing, is the secondary endpoint. 2-year cutoff, there was no improvement in event-free survival. But when you look into the 3rd-year cutoff, there was an absolute gain of 7.7. You discuss about Catherine 11. 7.7 is a significant number, with 37% reduction in event when you gave pembro in neoadjuvant followed by adjuvant. Now, most important thing, and a question that arose was, what about patient who achieved pathological CR and patient who did not achieve? Now, if you see in both the arms, those patients who achieved a pathological CR, 92.5% versus 94.4%. So whether you really require adjuvant pembro because you have achieved a pathological CR, and in both the arms, the overall survival is 92.5 and 94. So that is a question that is unanswered. But if you have not achieved a pathological CR, giving it in the adjuvant setting, again increase your pathological CR, the event-free survival by more than 10%. So 56.8 versus 67.4. So yes, you should give it in an adjuvant setting if you don't want to give a capecitabine. In terms of nodal analysis, the quantum of benefit in node positive is more, but the important takeaway is in both the subset, node positive, node negative, the pembrolizumab gives a substantial improvement in pathological CR. When you talk about event-free survival in staging, again you see stage 2 88.6, stage 3 71.8. So there was a statistically significant improvement in event-free survival irrespective of stage 2 and stage 3. When you look into local recurrence, again lesser. And when you look into distant recurrence, again lesser when you give pembro. So it works in both ways, potentiating your local as well as reducing your systemic recurrence. Now, when we talk about overall survival, again it is at 3 years. But if you look into HR, 0.51 to 1.02, just reaching, but still it was not statistically significant. But I think we should wait for a year or two to see whether it really improved the overall survival. But please remember the 2 of the endpoint, which was primary pathological CR, event-free survival, both improved, and this was a positive study. So based on this study, July 27, 2021, FDA has approved pembrolizumab in high-risk early TNBC as neoadjuvant followed by adjuvant. Now comes the important question that I took out from the debate, the discussion. Do you really require a IO therapy in a adjuvant setting? Because if you look into those patients in durvalumab, if you remember your JAPAR-NEVO study, it included only neoadjuvant arm. And if you look into 3-year overall survival, it was 85.6. And when you look into pembro, it is 84.5. Again, these are cross-trial comparison, but something that we need to understand, how long to give pembro. If you have achieved a pathological ER, really you should give your pembro in a adjuvant setting or not. Looking into adverse event, one more important is discontinuation rate was 27.7, which is quite high. 1 in 4 discontinued combination of chemo with immuno. However, when you talk about immuno as a culprit, it is 10% only. So probably, yes, there is some things to say that tolerance-wise, 1 in 4 discontinued is a slightly bigger number. Why did Keynote 522 succeed? You remember your NeoTrip PD-L1 study? Probably that study failed and we don't have, because this is the most important thing they discussed, which is the ideal partner to be combined with IOs or a chemo checkpoint inhibitor. So the two best drugs are platin, cisplatin, and doxorubicin. And if you remember in this study, platins were also included and doxorubicin was included with IO arm. Of course, you need to debate, but the data suggests that these are the one of best drugs which you should combine with IO to get a good immune response, as has been studied in the ISPY2 also. So the first take-home message from the neoadjuvant, and that was takeaway from this SABS was, Keynote 522 regime improved event-free survival by 7.7% in high-risk TNBC and has become a standard of care. Three questions that we keep on discussing is, in all IO benefit is conferred by neoadjuvant administration, or you really require a adjuvant IO also? How do you reconcile or combine with standard of care capecitabine? We remember our CREATE-X study. Or how do you combine it with oraparib in germline mutation? I would like you to remember that there is a synergism between PARP inhibitor and IO, as seen in metastatic setting. Remember your Mediola and TEPEZZIO study. So yes, probably in future you may have a data or trial which may combine both. And the last thing is, which is the best drug to be combined with IO? Should be a taxane, should be a platin, should be a anthracycline. Now comes to the second part. What was a takeaway from the SABCS 2021 setting? So two pivotal studies here. Now this was in summary. Again, if there is any students who are sitting, if you have to discuss metastatic, these are the three pivotal studies, but the update came in the most important study again was a Keynote 355, which was a Pembro study which combined with Pecli or a nab-pecli or a gemcarbo. So these were the recommendations that they give. All patients in metastatic TNBC should be tested for PD-L1, TMB, and MSI. All patients who are candidates for immunotherapy should have a tumor tissue tested for PD-L1, at least one, irrespective of the prior therapy. You should not test your PD-L1 in the early stage breast cancer. And for me, this was more important. At what site you should do a biopsy for testing PD-L1 is, it should not be liver. Please remember, extrahepatic, because PD-L1 positivity on liver tissue was less than 20% versus 63% when you take primary breast as a tissue. And at least once you should test your NGS or PD-L1, and probably the best time is at first relapse. So the pivotal study 355 was again untreated TNBC or recurrent at least 6 months after Pembro with chemo versus chemo only. And here there was subgroup analysis of 1 to 9, 10 to 19, and more than 20. So if you remember, around 55% it was combined with gemcarbo, and in 45 either a Pecli, which would be nab, or a Dino or Peclitaxel. Around 38% of the patient totally had a CPS of more than 10. Now, when you look into the first subset analysis, PD-L1 of more than 10%, there was a reduction in the risk of death by around 27%. Absolute gain of 6.9 nearly months, 7 months, and it reached 23. Now, when you look into PD-L1 CPS more than 1 or intent to treat, please remember, it has cross-unity hazard ratio 1.05, 1.2. So all the benefit which was there was driven by those with a CPS of more than 10. So no improvement. Now, this is most important. What in 10 to 19 and more than 20? When you look into hazard ratio 0.71 and 0.72. So yes, the quantum of benefit or the benefit of immuno came in those with a PD-L1 of more than 10. What about less than 1 to 9, 0.97 and 1.09? So no use of giving this drug in CPS less than 10. Now, when you look into PFS, again, benefit in all the three subsets. But again, I will like you to remember that this was driven again by those with a CPS of more than 10. Now, again, when you look into the update, 10 to 19 and more than 20, 0.71 and 0.62. Again, the quantum of benefit is more if your PD-L1 by CPS is more. And if you look into less than 1 and 1 to 9, 1.09 and 0.85. Again, reiterating that all patients should not be given and it should be CPS more than 10. Look into adverse effect. Discontinuation rate is 18.3% and grade 3 to 5 was 68%. But more importantly, what was immune-related adverse event? So led to discontinuation is only 2.8 and grade 3 to 5 was 5.3. If you remember your Atezo trial of IM patient 130 and 131, it was 10%. So probably in metastatic grade 3 to 5, adverse events were lesser as compared to the Atezo trial. So the take-home message from this trial was that there was meaningful improvement in PFS and OS versus chemo in those with a CPS of more than 10. CPS more than 10 is a reasonable cutoff to define a population who are likely to benefit with pembro plus chemo. Safety profile was consistent. The second study and the last part of my presentation is what is the TMB in which you should use your combination of IO plus IO. If you remember your keynote 158, which was a main study, TMB more than 10 should be taken irrespective of which solid tumor you are taking. You can give your immune checkpoint, but it is not the way. Probably this is a better sophistication. So multiply treated patient with metastatic HER2/neu, TMB of more than 9, combine, this was a phase 2, so a single arm Nivo plus Ipi till progression. Now, if you look into it, the main primary endpoint was response rate. Secondary endpoint, I would like you to remember ORR and TMB more than 14, which was a pre-specified secondary endpoint with PFS, clinical benefit rate, and safety. 30 patients, 5 patients had a TMB of more than 14, and 25 had 9 to 14. Now, when you look into the response rate, only 5 responded out of 30. And the clinical benefit rate, if you see, it was only 5. So what are these 5 patients are most important? Out of these 5, 3 patients had TMB of more than 14. So if you look into it, out of 5, 3 responded with the response rate of 60%. Now, when you look into the survival in these 5 patients, the progression-free survival is 9.5 months. The overall survival is not reached. When you look into the toxicities, again, only 3 patients had grade 3 toxicity. So toxicity was consistent as we have seen in other IO, and there was no grade 4 to 5 adverse event. So what did this trial suggest? High TMB, if you say overall, it was only 16.7. If you remember your TAPOR, it was 21. But the most important thing they suggest is probably 9 is not the way, or 10. It should be 14, because patient with TMB of more than 14 mutations were a minority, but they achieved the overall response rate of 60%, and further work is needed to investigate which is the optimal TMB for selecting patient on ICI therapy. So probably this is something, this was interesting and was one of the most talked about trial in this SABCS. So I have summarized my metastatic in a single slide. How do I treat my patient in a TNBC in a metastatic setting? This is according to FDA. Locally recurrent metastatic TNBC with PD-L1 of CPS more than 10. And if it is second or third line, all MSI high or deficient MMR or TMB high solid tumor with progression on viral line. And please remember, atezolizumab has been withdrawn from the market for this indication. Even the Indian authorities have told them not to promote atezolizumab in this indication. So the 2 indications where you should remember, you should think of, and the pembro is the only drug you should think of giving in your TNBC. I thank you all. There were 3 updates, which were probably one of the major, lot of posters, which I don't think so carried any good message till now. I again thank Dr. Rahul, Dr. Vivek, and Tarun for this kind invitation. Thank you all.
Thank you, sir. Thank you for taking us through the recent SABC updates, and many were really practice-changing for us. So thank you once again. So we'll move on to the last topic, and one of the important, difficult topics in breast cancer, which is likely not well defined. So the topic is oligometastatic disease, definitions and practice patterns. So to speak on this, I would like to welcome Professor Meena Walia, who is the senior consultant and head of the Department of Medical Oncology at Max Cancer Institute, Pratapganj, Vaishali. Ma'am, over to you.
First of all, before I begin, I will really want to thank Dr. Vivek, Dr. Rahul, Dr. Vijay, the organizers, for this opportunity. And thanks, Tarun, also for all the cooperation that you have always been doing. And I hope I am audible and my slides are visible too.
Yes, ma'am, you are audible and visible.
I happen to be the last session for today, last speaker for today, and I promise the viewers that I won't hold them long between the dinner and this session. So I will try to keep it as crisp as possible. Sure. So I have been given the topic of oligometastatic disease, definition and practice patterns. So if we go back to way back in 1804 and I'm taking breast cancer as an example. So the Halsey story theory said that it is a localized disease. For that matter, once upon a time, we all thought that cancer was a localized disease. And it took more than a century, more than 150 years, that Fisher et al. In 1980 came up that breast cancer is a systemic disease even at its inception, and hence the role of systemic therapies. So, in practically speaking, in today's date, even when we can easily say that when we are talking of malignancy or when we are talking of cancer, is it really localized when we talk about it upfront? So we know there is a spectrum. There is a spectrum of pattern. What appears to the eye as localized, we still know that cures are possible, but which appears as a disease which is spread to multiple sites, then basically we go for systemic therapy, and local treatment may be required for something like toilet mastectomy or for symptom control. But there is definitely a term, a state in between, which is where we can say the meds are there, but they still appear to be quite localized, and in a subset of these patients, cure may be possible. So again, it is oligometastatic disease is basically a specific condition between a disease which is curable and a disease which is definitely incurable. So somewhere in between, we have a few subset of cases, few cases which maybe possibly can be treated with a curative option, and not a stochastic oddity as said by Hellman. It is based on a state of limited metastatic capacity, and rather it is not only with one particular tumor or one particular disease, rather a characteristic of many tumors during their clinical evolution. So if we look at the biology of the disease, if we look at the molecular pattern, the micro RNA expression, is it different between the oligometastatic disease or a polymetastatic disease? Then the answer is no. The biological features may tell us that the patients who present with oligometastatic disease may have a favorable biology or may have less heterogeneity. But patients who present with polymetastatic disease, again, the heterogeneity is more. But can I divide? Because it will take me a very, very long time to actually ascertain whether this particular patient, this metastatic disease is going to have a favorable biology or a poor biology. So at present, what is that tells us, that helps us in diagnosing the oligometastatic disease? Needless to say that biological rationale may be there, but will definitely not help me. No molecular markers are there that can be defined used for oligometastatic disease. It is presently basically only imaging defined. So as the imaging advances, the newer technology in imaging, probably more and more of these oligometastatic disease, which we actually thought of locally advanced disease, probably will be identified. And hence, there will be much more recommendation of incorporating the higher advanced imaging technologies even in the early cancer. So for example, we know that in the oligomer inclusion, the imaging techniques which have been advocated is something like PET-CT for each and every patient, and an MRI also of the brain, so that you can actually identify the subset of these oligometastatic disease. So there has been lot many debates, lot many discussions, and we have one of those latest consensus recommendation from both for ESRO and EORTC. So it is not putting a label of oligometastatic disease. It is not one disease. It is not always the same. So there may be lot many factors. Is it actually a oligometastatic disease, which is de novo present as oligometastatic disease, a genuine oligometastatic disease? And if it is a genuine oligometastatic disease, is it de novo oligometastatic disease, or a disease which had earlier presented as an early disease or a locally advanced disease, and now in a recurrent setting, it is a oligometastatic disease? If it is a de novo oligometastatic disease, whether it is a synchronous or it is a metachronous oligometastatic disease. Similarly, there may be a spectrum of patients which have been induced as oligometastatic disease, were polymetastatic to begin with, and over a period of time, after systemic therapy, there was only residual oligomets, or possibly the mets disappeared and then it again started increasing, induced oligometastatic, or while on systemic therapy, the lesions initially decreased and then progressed further. So it is not as simple as saying that it is oligometastatic disease. So you have, this is just a diagrammatic representation of that complicated chart which I just showed. It can be either de novo oligometastatic disease, a disease presenting with oligometastatic disease, which can be synchronous within 6 months, or it can be metachronous one after another beyond 6 months, or it can be metachronous oligoprogression also while the patient is under treatment for the metastatic disease. Similarly, it can be a repeat oligometastatic disease. A repeat oligometastatic disease, possibly a localized disease to begin with, and then the patient presents as a oligometastatic disease after a treatment-free interval, or a repeat oligoprogression appearing after a treatment-free interval and then while on systemic therapy again progresses, but it is a oligoprogression, or a repeat oligopersistence, repeats after a time but remains as oligometastatic, and while on systemic therapy it persists as oligometastatic. And again, there is a whole spectrum of induced oligometastatic disease, which can be induced oligorecurrence or induced oligoprogression, initially induced from polymetastatic to oligometastatic and later progressing or persisting. So there are finer differences between these definitions, and possibly can they all be clubbed together and dealt the same way? And then it is again a topic of debate. We know that the age-old dictum remains. So do all of them behave the same way, whether it is de novo or it is a repeat or it is an induced oligometastatic disease? We know that the disease which is less to present, so that is the reason that repeat oligometastatic disease, which were earlier probably early or locally advanced and later after a treatment-free interval now presented as oligometastatic disease, or a de novo oligometastatic disease, are the ones which will have the best outcomes and the best survivors. A patient who had a polymetastatic disease and later turned into oligometastatic disease, and the outcomes will definitely remain poor compared to the other oligometastatic diseases. So the definition seems to be evolving over a period of time. Both ESMO and ESTRO have used variable definitions, but the basics remain the same. It is a low volume metastatic disease. There is a limited number of the mets and the limited size of the mets. 5 centimeter being the common magic figure being used by most of these trials. And again, less than 5 lesions and a controlled primary lesion seems to be the most desirable thing. But the basic crux is where all the metastatic sites can be safely treated, can be easily treated, and with a curative intent. So the definition combines an artificial description with the possibility and choice of implementing a therapeutic strategy with a curative intent. So all the different scenarios which I have already highlighted may present as an oligometastatic disease, and it actually is a spectrum. It is a spectrum of disease, and of course, being oligometastatic, but whether it is an oligorecurrent or oligopersistent or oligoprogression, the outcomes may be very, very different for each and every patient. So if we go for the incidence, and if we are talking of primary breast, so oligometastatic, the incidence seems to be quite variable. In metastatic breast cancers, 50% of these cancers seem to be presenting as oligometastatic disease or the de novo. But whenever it is a oligorecurrence, if we talk about, then 17% of the cases in early breast cancer trials presents as oligometastatic disease at presentation when the mets occur. Survival again depends on the number of mets possibly. So less than 5 mets, 3.5 years. These are from the various studies. 6 to 12 mets, almost 2 years, and something less than 2 years if the number of mets further increases. So a number of mets is also an important. Now, the next big question is, all these oligometastatic disease, Is systemic therapy the only option, or we need to add the local therapies also? So coming to the two important local therapies, yes, surgery and radiation. Should surgery be offered in metastatic breast cancer? And if yes, when should it be offered? So there are very, very special indications where one can think of these local therapies in a patient with metastatic breast cancer. So clear data does show that clearly selected metastatic patients. So the word to be highlighted is it is the selected metastatic patients who may benefit from surgical management. Generally the younger patient, those with highly hormone receptor positive tumors or possibly the bone only disease. In inflammatory breast cancer also now incorporation of local therapy seems to offer better overall survival. However, all the data that we have is generally retrospective, and we don't expect that we will, in near future, we will have a prospective randomized trial in this case. And a very common scenario, contralateral axillary metastasis. So again, a thought process, as was for supraclavicular lymph node some years back. Is it really stage 4? So in contralateral axillary metastasis, many of us currently offer local therapy also in addition to the systemic therapies, and select patients may benefit from palliative local therapies also. So we have a lot of randomized control trials. However, majority are phase 2 trials, no phase 3 trials so far, which have shown that in various histologies, whether it is prostate, lung, colorectal, or breast, and the addition of these local therapies in some form, whether it is radiation or surgery, may be adding on to the progression-free survival, and maybe some OS also. But the numbers are so few, and it is the data from very limited trials. Again, upcoming something which is really very talked about with lot of emotions and positivity is SBR. It is SBRT therapy, radiation therapy. And we have much more data in this setting that does show that in the SBRT or local radiation therapy arms, these oligometastatic disease does better. And we have better local control as well as possibly better PFS advantage also. So further questions will be answered by a lot of ongoing clinical trials. We have consolidative use of radiotherapy to block oligoprogression and so many other things. And we have our learnings from certain other settings also. For example, in lung cancer, in oligoprogression, where we are frequently now adding local radiotherapy to systemic therapies. However, there seems to be a very, very long time before we can extrapolate this data to our clinical practice, because over a period of time, the radiation technologies have really changed. There is the change in the surgical techniques. The systemic therapies have really evolved. Better imaging modalities, the whole spectrum of oligometastatic disease seems to be changing. So there are many things which have happened. Can we extrapolate this data from our clinical experience from the clinical trial to real world evidence? So we know that it is the real world evidence which is more important. Why? Because there is a continuous change in the radiotherapy technology, the imaging technology, the surgical things, and the generation of evidence from the clinical trials alone is going to be very, very unachievable and maybe too slow. And not all clinical questions can easily be answered by a clinical trial. So we have another ongoing, very important clinical trial, that is the OligoCare, and the initial results includes many patients with many different sites. And for shortage of time, I'm not going into all these real world evidence. Also, some of the real world evidence from Belgium, England, and ongoing trials, which do talk about combination of these local therapies and not adding much to the toxicity and improving not only the local control and to some extent PFS also. So metastasis directed therapy has now become a norm has now been, rather I will say not a norm, it has now become more acceptable in various conditions, in breast, in lung, and prostate also, so many other this thing. And yes, because why we are still lacking the definitive evidence, because of the large variability in definition that has been used in literature all across, and different definitions have encompassed everything. Some have talked about the outcome, some have talked about the disease burden, the disease type, and the disease sites also. But what is the consensus? The consensus is that it is independent of the primary tumor, it is independent of the metastatic location, and it is independent of the presence or length of the disease-free interval. And it is a big spectrum. It can be synchronous, metachronous, systemic therapy induced oligometastatic disease, and not all of them behave the same way. The ability to deliver safe and clinically meaningful radiotherapy, rather clinically meaningful local therapy with curative intent to all metastatic sites, is a minimum requirement for defining the oligometastatic disease. In context of radiotherapy, it says for radiotherapy. So I would like to conclude by saying that at present, there is a large variability depending on all these factors, but how we can summarize, it is basically to say a limited disease, limited metastatic sites, less than 5 in most of the studies, and not more than 5 lesions in any one organ, a controlled primary tumor being optional, but definitely more desirable, and at all the metastatic sites must be safely treatable. It doesn't depend, the term oligometastatic disease is not dependent on the primary tumor, neither it is on the site of the metastatic site, and the detection of oligometastatic disease may further increase depending on the further incorporation of high resolution imaging that we use in our clinical practice. And there is an increasing role of multidisciplinary treatment in management of this subset of diseases. With that, I say thank you.
Thank you, ma'am. Thank you very much for that very informative talk on less discussed topic, I would say. I think more and more evidence will help us identify these subset of patients in treating them better. Although, as you rightly pointed out, clinical trials are very difficult in this situation. Thank you very much, ma'am.
Once again, I thank everybody, the organizers, for a wonderful conference, and I've been listening to all these sessions. Really very interesting and very well thought of topics.
Thank you, ma'am. Thank you. So with that, we come to the end of today's session. So I would like to thank all the speakers, moderators, panelists, and all the participants who have actively taken part in this meeting today on breast cancer and some of the updates of recently concluded SABC. So I've always learned something new from each meeting, and I hope so that all of you would have done the same. We would have learned something new. So I think we had a very good extensive discussion and presentations on various topics, starting from diagnostics to metastatic setting, and even some of the updates on recently concluded SABC. So I would like to thank all the presenters once again. So I would like to thank the scientific committee comprising of Dr. Rahul Sood, who is the head and senior consultant medical oncologist at Command Hospital, Bangalore, and also Dr. Vijay Agarwal, who is not there today. I take this opportunity to thank our sponsors of today's meeting, Novartis, Zydus, Pfizer, and Roche. Thank you. Finally, I would like to thank Horizon Group, Mr. Tarun, who has been able to conduct these meetings without any technical glitch or any problem. Thank you, Tarun. I thank all of you once again, and good night.
Thank you, Vivek and Dr. Rahul. Thanks very much. Good night.
Thank you, sir.
Thank you, everyone from the organizing teams, my colleagues, Aru and Pooja. It's been a great journey. So thank you so much. Have a nice weekend. Stay safe till we meet again. So Dr. Vivek and Dr. Rahul, I think everyone is looking for a chill beer. Next time, let's meet physically. All the very best. Bye-bye, sir.
Hoping to meet.
Thank you, Dr. Bharat. Thank you, Dr. Vivek.